Good afternoon, everybody. Thanks again by your presence for the second day of the third international meeting of our Metabolic Disease Multidisciplinary Center in Clínica Santo António, Amadora, Lisboa. It's a pleasure and an honor to have you all here. We have here a lot of experts, the top experts from Europe and Brazil and other parts of the world. Welcome to all. Thanks for being here and thanks for your friendship expressed in the presence in this meeting. Also to all the participants, I want to thank, and we had 300 registrations, attendance, so mostly in Portuguese language, but a lot of them also from different countries like Peru, Mexico, India, and even Russia. So it's a kind of wide panel of attendance. Yesterday it was, we had a nice session. We had the maximum of 110 simultaneous participants, and we are quite happy with the outcome. So let's do better today. Let me say that this is, my team is in a private clinic that is part of a Portuguese group, which name is Lusíadas Group. We have a lot of hospitals in all over the country and a lot of small clinics for ambulatory healthcare. And I'm going to run a video, a promotional video from this group that in the end belongs to an American company, which name is United Health Group, one of the biggest in the world.
Caring. This is the main word which guides Lusíadas Saúde's work, and what drives those who believe there to be a difference between being able to treat patients and possessing the knowledge, technology, and calling to care for patients. As a result of this drive and an intensified focus on safety and quality, Lusíadas Saúde has become the first private Portuguese group with hospitals accredited by the Joint Commission International, as well as the first to be distinguished with the HIM certification, which assesses the integration of technology to the benefit of patients. With a network of services across Portugal, Lusíadas Saúde has 4 strategic pillars: clinical excellence, best care experience for our patients, human capital development, efficiency, and sustainability. Our core commitment is represented in our mission to help people live healthier lives and to help make the health system work better for everyone. Lusíadas, caring is in our nature.
So this is our Bible, if you want. Okay, this session, the two-day session, is about revisional surgery. As you know, this is a very, very important topic nowadays because the rate of revisional surgeries all over the world is increasing more and more. We know that in the United States, it's about 20% of all the bariatric or metabolic procedures, and even in certain setups, it can be greater. In my previous public hospital, for instance, the last year, we had 48% of revisional surgery and only 52% of primary bariatric surgery. So the frequency is increasing, and as you know, even I suppose since 2015, the definition of bariatric surgeon implies that yes, at least some experience in revisional surgery, something that we need to face. We are not allowed to forget this topic, and we need to train and to think about the issues of revisional surgery before going to the practice. So it's good to listen to the experts, and we have here a bunch of very, very expertise people about this topic. We have moderating the table Professor Rudolf Weiner and Dr. Raquel Santos, and a lot of speakers that will be presented later on. Professor Rudolf Weiner is maybe the more experienced European bariatric surgeon, as everybody knows, more than 35 years of experience about bariatric surgery. Of course, he was the founder and president of the German Society of Bariatric Surgery. He was the former head of department of one hospital in Offenbach, Obesity and Metabolic Surgery and Sena Clinicum. And he was also a IFSO president in 2014 and 15. And he has been distinguished with different awards, one of them by ASMES. but mostly he's a very, very kind guy, very friendly man, and always open to assist each one that has problems and can ask him for help. So I have a great esteem by him, and it's an honor to have you here, Rudolf. Dr. Raquel Sanchez is also a friend from many years ago because we are quite close. She works in the north of Spain, very close to Portugal, and we have been together in not lots, but several, many meetings and educational courses, mainly in the labs, in the wet lab. And she is a chief of service in a general surgery in Complexo Hospitalário Universidade de Vigo. Vigo is a city above Portugal, very close, 25 kilometers, I suppose, and very close to the Portuguese culture. She is now the president of the Spanish Society of Surgery Obesity, the SECO, a big and well-organized society with a lot of activities that we have been working together with the Portuguese society in different activities. And is also the president of the scientific committee of the Spanish Association of Surgeons in general. So welcome, Raquel, also, and I would give the podium to you. Please do the job, and good luck, and thank you again for being here. Hugo, temos que passar para o professor Feiner e para a Raquel.
Thank you, Rui, for the kind invitation. It's a pleasure to be here with you.
Thank you.
Rui, congratulations for this very excellent meeting. The first day was very successful, so we are sure that this second day will be also very successful. And we will start with the first session about the regional surgery. And maybe I can introduce, maybe not necessarily, Alexander Naimak from Russia. He knows him as a member of a very active person in the Young IFSO. He's also a current president of the Russian Society for Bariatric Surgery. And he is chief of scientific research laboratory in Russia. And he will present the first topic about the preoperative workflow and criteria. So Dobro Povozalovac, we можете начать. You can start.
Okay, I just launched my presentation. First of all, thank you, Rui, for invitation. It's a really great Congress. Yesterday was very nice program, very interesting, very good debates, and I hope today it will be great. It was nice to see all the experts, all the people, because it's a difficult time and we can't see each other regularly in some conference, but it's all times a possibility to sense a little bit each other, to speak with each other. Okay, my topic it's preoperative workflow and criteria of the revisional surgery. It's a little bit difficult because it includes so many issues, but I try to speak a little bit about. First of all, the three simple reasons of the revisional surgery: so medical complications, it's weight regains. I think it's maybe main reasons of the all bariatric surgery, and insufficient weight loss. It's very specific indication, but it exists. What mean? Weight regain, it's 65% of the patients who received bariatric surgery, except BPD, duodenal switch. The nutritional and lifestyle compliance is a crucial factor in maintaining long-term weight loss, and research has shown that poor weight outcomes have been associated with non-compliance with post-operative nutritional requirements. But we will speak a little bit later about it. And now about medical complications, because normally it's problem with surgical techniques or some anatomical problems. It's maybe fistula, it's severe reflux, it's ulcer disease, it's stricturous, it's internal hernia, it's erosed gastric rings, it's slippage, it's malnutrition, and many other medical complications. It can be in early period, it can be in late period after procedures, but anyway, it's an indication for a revisional surgery. In this case, you never decide to do or not to do. You need to do it, but it's very difficult always the choice what to do. But I hope there are other speakers can a little bit speak about it, and we can debate after that. The weight regains, it's, as I told, I think main reason of the revisional surgery in bariatric surgery. As we see, for example, SOS study and other many, it will be example that we always have a weight regain after 2-3 years. It's not depend of the procedures. It can be gastric bypass, it can be sleeve gastrectomy or any other. And we can see, for example, sleeve pass studio, and we see that the same graphic. We can see that at the beginning, the first 2 years, the weight stable and she go down, but then many people gain weight. And if we see, for example, because we have many articles with this data, but for example here, we can see that 4 or 5 years, the more than 10 kilogram, it's 57-60%, and more than 25% of the maximum weight loss, it's about 50%. It means that every second patient have a problem with weight regain, and she gain more than 25% of weight. But how we must to evaluate the weight recidivism? It's normal, it's not normal. Sure, I take it from the article of the Stacy Bretthauer. The morbid obesity is a chronic disease, and acceptable long-term management after the primary bariatric procedure should include the surgical options of conversion, correction, or other adjuvant therapy to achieve an acceptable treatment effect in cases of the weight recidivism, inadequate weight loss, inadequate comorbidity reduction, or complication from the primary procedure. Why I citate this? Because the weight regain, it's a process of the chronic disease, obesity, and we need to understand that we have this option and we need this option, the revisional surgery about weight regain. What the factors associated with weight regain? Now, sure, it's dietary non-adherence. For example, high calorie intake, high intake of carbohydrates or alcohol. It's psychological factors. It's different diet-related behaviors disorders or psychological factors like anxiety and depression. It's a lack of support. It's very, in our practice, we very often seen that the patient didn't receive the support among the bariatric professionals, didn't receive any psychological support, for example, in family, because as we know, the obesity for many people, it's not the disease, it's only a problem of the behavior. It shows the physical inactivity because it's very difficult to try implement the exercises in your life when you receive first years the result of weight loss without something. Okay, what we need to evaluate of the candidate for regional surgery. It's a clinical symptoms. It's a chronic pain, dumping syndrome, heart burning, and many, many other symptoms. The eating behavior is very important because sometimes we can correct it and don't take the patient to the OR, especially for weight regain. We can try to treat them with dietitian, for example. It's a psychological status. It's depression, it's anxiety, it's stress, it's anger, and other. And it's the same situation. We need to evaluate it and then to try correct, because sometimes it's happened, and as I told, in our practice, it's very often when the patient with the problem with psychological status have a good result after psychological treatment, after, for example, 5, 6, 7 years after procedure. And sure, it's very important things. It's commitment to treatment. It's weight loss programs, which include diet and exercise recommendations. It's behavioral therapy, skills training, etc. But it's very difficult because, as we told before, our patients did not very compliant. After the evaluation of the status of patients, we need to evaluate some anatomical problems. It's X-ray, it's CT scan. X-ray normally it's, for example, double contrasting. We look the anastomosis. We look the large of esophagus, the size of pouch, the CT scan volumetry, and for example, it's very important for internal hernia. It helps us to understand what happens if, for example, the patient have a chronic pain. The endoscopy of upper GI, it's a very important point because, as we know, the many sleeves was very uncontrolled, and now uncontrolled, and now we have the problem with some reflux, some Barrett's, and we need to correct it. And sure, the different labs things, it's protein, vitamins, and etc. A very important point where we need to do the regional surgery. Sure, it must be the big high volume center with experienced surgeons, with multidisciplinary teams, included a dietitian, endocrinologist, psychologist, and other people. And sure, where we provide early rescue for postoperative complications, because we know the revisional surgery, it's a high rate of postoperative complications. It's a citate from the Bachwald article. The revisional surgery demands a dedicated, skilled, and experienced metabolic surgeon, a hospital facility and personnel capable and willing to care for the difficult postoperative patient, and the supportive administration dedicated to patient care first and foremost. It's very important words because we really think about our patients, and we need to, and we speak that now the regional surgery grow up, and sure, in this growing, we need to save the safety of the bariatric surgery. Who is candidate for regional surgery? Normally, it's the people who 1.5, 2 years after primary procedures, not early. It's insufficient weight loss, less than 35, 40, or 50 excess weight loss. The patient received treatment by dietitian, psychologist, fitness instructor at least 6 months, and patient with malnutritional problems with clinical symptoms and non-response of therapy. Who is not a candidate? It's very important. It's a young patient who wants to have an ideal weight. It's a very specific group of patients. The patients with BMI less 30 and don't have a progressive increasing of weight. The patient who doesn't want to receive a conservative treatment before regional surgery. And sure, patient with depression, alcohol abuse, drugs abuse, and other problems, psychological and other things. Conclusion: the decision on the revisional procedure should be as balanced as possible, and we need to count on the fact that you will do the final procedure, but not next. Thank you for your kind attention.
Thank you very much. Spasibo большое. Obrigado. Maybe Rachel, you like, we will discuss all 4 presentations at the end. Maybe you, Rachel, you would like to introduce Jacques Pauwels, the next speaker.
Me?
Yeah.
Jacques Pauwels is the next speaker. He's an MD and PhD holder at the Department of Intensive Care Medicine of Surgery in the Elizabeth Trisden Hospital, Tilburg in Netherlands. He is a co-founder of the Global Bariatric Research Collaborative, and he is interested in the broad spectrum of obesity research. He has a really great experience in research, and mainly in the effects of bariatric surgery and physiological changes due to obesity. He's going to speak today about the role of imagiology in the revisional surgery after bariatric and metabolic surgery. So, Dr. Pauwels, whenever you want.
Yes, thank you very much. I'll share my screen. Yeah, first of all, Rui, thank you for the kind invitation. Professor Weiner, Dr. Sanchez, thank you for the introduction. I'm going to talk about the role of imaging in revisional bariatric and metabolic surgery, a difficult topic, and I will start with a few basic rules, as I remember from a year ago, before the COVID situation started to flame up here in the Netherlands. I have no disclosures, despite the fact that the only images I see nowadays are chest CTs, chest X-rays of COVID patients, which is a bit different and sometimes a bit boring. In terms of imaging, we have a lot of complications and a lot of problems that can occur after bariatric and metabolic surgery. And so we have a lot of reasons why we should and why we could revise a bariatric surgical procedure. And in terms of difficult subjects like imaging, it's first most important to objectify why we need to visualize something. I'll give an example. If you have a patient with fever, 39 degrees Celsius, shortness of breath, and oxygen saturation of 88%, and all the near family members were tested for COVID, then your differential diagnosis is COVID, of course. And if you make a a chest X-ray and you see this, and you have your diagnosis. And in this way, your chest X-ray is supportive of finding your diagnosis. That's basically what it is in general clinical practice. And my presentation got stuck, I think.
Can you click on it, please?
Yeah, I'm trying, but it totally froze.
Can you use your arrows, maybe?
No.
You want to stop sharing for now? Can you try to share again?
Let's see what happens here.
There we go. Put it in presentation mode.
Yeah, my computer froze. Sorry, guys. Can't help it.
I'll stop sharing for now. Okay.
That was because COVID's image, probably.
Yeah, it's probably. Give me a few
Can you
seconds.
maybe try to close and reopen it again, please?
Well, maybe we could jump to the next presentation, and meanwhile, Jai can fix the problem,
Yeah.
and we'll come back with the presentation. What do you think?
Yeah, that's okay.
Okay.
So,
Okay. So please, Professor Rudolf Weiner, do you want to
Well,
present David Serra?
yeah, I'd like to introduce David Serra. My Portuguese, David, not David. He's a specialist in gastroenterology, at the Portuguese Medical Association and the European Board of Gastroenterology. And he's working as a coordinator of gastroenterology in Cube Lusíadas, as a director of Centro Endoscópica Advanced in Lisboa. And he will talk about the role of endoscopy, because it's an own field, bariatric endoscopy. And so, David, please start your presentation. 12 minutes, and then we discuss all the papers at the end. Hugo, it's ready, yes? Yes.
Hello. First of all, I would like to congratulate Dr. Rui Ribeiro for this wonderful meeting, and I would like to thank the opportunity to participate in this meeting. In the next few moments, I will present my talk about the role of endoscopy in revisional surgery. Don't preserve disclosures in this talk. As you know, obesity is the other pandemic that we have to deal in 2021. And even after gastric bypass, patients have the potential to experience significant weight regain. The bariatric endoscopy is a new member of the obesity unit and can provide three alternatives. First, can provide primary endoscopy procedures for the management of obesity. Second, revision procedures for patients who experience weight regain after bariatric surgery. And third, dealing with the complications of bariatric surgery, including perforations, leaks, stenosis, and fistulas. As you all know, the causes of weight regain after gastric bypass are multifactorial And we have to deal with genetic, environmental, psychosocial, and also modifiable risk factors. Among these, the two most important are gastrogastric fistula and gastrojejunal stoma dilatation. This paper presented a few years ago shows us that the aperture of the gastrojejunal anastomosis is correlated with weight regain. And the large stomal size was the single greatest predictor of weight regain. And when we deal with a patient presenting anastomosis bigger than 15 millimeters, we should consider endoscopic revision. This graphic shows us that the direct correlation between the stoma diameter and the percentage of weight regain, so the direct correlation between both. The endoscopy treatment primarily is aimed for patients that have performed gastric bypass and less commonly for those with undergone laparoscopic sleeve gastrectomy. We know that about 30% of the patients will experience some degree of weight regain, so this is a common problem in our units. What we can provide? So we have argon plasma, we don't use any more sclerotherapy, the transoral outlet reduction, the TOR method, using the Apollo endosurgery, the revision obesity surgery endoluminal, the ROSE method, and in the last year we have different small series with the use of experimental methods like radiofrequency and ESD. The argon plasma is a method that produces scar tissue formation around the anastomosis, and with that scar tissue, we try to achieve a reduction in the diameter of the anastomosis, like we see in these pictures. This paper presented in 2015 showed that after 3 sections of APC separated by 8 weeks, we can achieve an average of loss 15 kilograms in each patient. In the last years, we start using the Overseas platform, the Apollo endosurgery, and this it was the method used for the transoral outlet reduction, the TOR. This next movie tried to show how it works, this method. So we start with the standard anatomy after gastric bypass, and this produces a reduction in the outlet flow to the jejunal, and we know that some years after we can deal with a dilatation of the anastomosis and also a dilatation of the outlet pouch. So these new methods provide a way to reduce using suturing, to reduce not only the anastomosis size, but also the diameter of the outlet pouch. And this is the way how it works, this method. And the final result is this, reducing the outlet flow to the jejunum. My preferred method is it's the combination of argon plasma and suture. So using first the APC on the margin and then the Apollo system for suture at second place. You can use different methods of suturing. It's a personal option. What matters it's the final result. So we start with argon plasma and then suturing, and we achieve a very good reduction of the diameter of the anastomosis. This video presents one of these patients. As you can see, we started with APC. You can see on the image the scar performed by the APC, and then we use the Apollo system to do the stitches around the margin of anastomosis. This is a quite safe method, as I will show you, and also with very good results. This present the final process of the method. You see, we are closing the gap between the margin, and the final result is very narrow anastomosis with the combination of the two methods. This paper, published on endoscopy in 2018, shows a series of 252 patients, and the technical success was 100%. The patients of total weight loss at 6 months and 12 months present very good results, as we can see on the graphics. This meta-analysis, published on the same year, with the evaluation of 32 studies, presented also very good results at 1 year. And as I told you, this meta-analysis showed that the outcomes were significantly higher with the group that used the combination between suture and argon plasma coagulation. Few months ago, it was published this paper on gastrointestinal endoscopy that shows a 5-year outcome of the TOR method. This paper included 331 patients, and the pre-TOR gastrointestinal size, anastomosis size, was around 23 millimeters, and after the procedure it was around 8 millimeters. And as you can see, the total weight loss after 1 year and after 5 years presented very good results. And no severe adverse effects were presented on this paper. So the conclusion is that TOR is safe and efficient arrested weight regain and provided durable weight loss in those patients. And what about gastric fistula? We can use the same combination. First, treat with the APC, and then suture with 2 or 3 stitches and close the gap of the fistula. An alternative method that was presented a few years ago, it was the ROSE method, using a different device. So this device works with, I will show you in this movie, with an alligator forceps that push the wall of the outlet, and then with this device we do plications on the wall, transmural plications that achieve a reduction not only of the diameter of the anastomosis but also of the outlet pouch. I present the final result, and this is the final result, reducing both sizes, and this is what the goal of this method. Some papers were published about this ROSE method, and this is the paper that presented a large series with 116 patients involved, with a technical success around 97%, with 32% of weight regain after bypass lost at the 6 months and no significant adverse events. After sleeve gastrectomy, the revision and the treatment option are the conversion to gastric bypass or a tent endoscopy revision. A small series have been published in the last years, and a few months ago, this paper was published on the endoscopy and presented 34 patients, and the technical success was 100%. And at 1 year after, 82% and 100% of patients achieve more than 10% total weight loss and more than 25 excess weight loss respectively. And no severe adverse effects were reported once again. The take-home message is weight regain after bariatric surgery is common and can be managed with less invasive endoscopy techniques. Endoscopy techniques target structural postoperative change that are associated with weight regain, most notably dilatation of the gastrojejunal anastomosis aperture, syringe suture placement, as well as argon plasma coagulation application to the anastomosis may result in significant durable weight loss. Various endoscopy approaches may be used to safely and effectively manage complications of bariatric surgery. The standard revisional surgery is more risky and less efficacious than primary weight reduction surgery, and endoscopy gastrojejunal revisions may provide a lower risk, cost-effective alternative. Thank you.
Thank you, Dr. Serra. I would like to check if Dr. Powell's fixed the problem. Maybe we can.
Hopefully, the computer with another presentation.
Okay.
I'll share my screen. Okay. Hopefully it works. Probably my other computer got infected with COVID in the meantime, but hopefully this one will do it. Can everybody hear me?
Yes.
I'm good.
Yes.
It sounds good. Thanks. Apologies. Where were we? The basic clinical rules of imaging in revisional bariatric surgery. Basically, as Dr. Nijmark already elucidated, we have a series of potential complications or problems. And the thing is, how can we visualize that problem or our reason to revise our surgery? And is it necessary to visualize? Second question you need to ask yourself is which imaging modality is the most suitable in terms of X-ray, CT scan, the more sophisticated things like multi-slice CTs, 3D volumetrics, and so on. And the third question is, with the information of 1 and 2, and of course your whole pre-operative patient workflow, can we think of a revisional surgical solution? Just a few normal anatomy pictures of the pictorial review of Galgano, published in the Journal of Thoracic Imaging in 2017. Everybody knows the normal picture of the laparoscopic adjustable gastric band. And in terms of radiological imaging, these are both contrast elucidated pictures with the contrast flowing through the band with the last arrowhead. And on an X-ray, the normal position is basically defined as a pi's angle between the vertebrae and the longitudinal axis, somewhere around 55 degrees. Secondly, the normal anatomy of the gastric sleeve, which looks in a contrast series like this, with normal passage through the sleeve stomach into the rest of the gastrointestinal tract, and the normal anatomy of the Roux-en-Y gastric bypass, with at the arrow the jejunal anastomosis. And these are basically the normal radiological studies we can find. I'm not going to discuss every complication, just a few, and just to elucidate how important it is to choose your imaging modality and what you're going to do with it. These two are both a chest X-ray and a contrast study on the left side and a CT scan on the right side of a patient with a gastropleural fistula and empyema after Roux-en-Y gastric bypass, with the fistula at the small arrow on the left side and the more big arrow on the right side on the CT scan indicates an empyema. Just to elucidate how difficult it is to come from symptoms, an imaging modality, to a surgical solution, I'll highlight a systematic review we did together with a few friends on behalf of the Global Bariatric Research Collaborative, of which I'm a co-founder together with Professor Mahawar from the UK. As you can see, we reviewed approximately 22 studies of gastric fistula after in particular chest fistula after a sleeve gastrectomy. And as you can see in the chart, there is a wide variety of symptoms, which makes it difficult. And I'll show that on the next slide. You see the diagnosis and exams that were done that led to an initial treatment. CTs, upper gastrointestinal series, gastroscopies, a bronchoscopy, a fluoroscopy, etc., etc. Only a few studies did no diagnosis, no imaging, or just a chest X-ray and an upper gastrointestinal series. And as you can see, there's a lot of information needed to form a good treatment plan, in which imaging can help you, but there's not necessarily a gold standard. This led to our treatment protocol we formed on the basis of those 22 studies. And of course, in this whole treatment algorithm, we left out all the imaging techniques because it's dependent on the capacity, how big your hospital is. Do you have a dedicated revisional bariatric surgical team? Do you have specialized radiologists that can help you? So those are all reasons to choose for one and another. This is a picture of gastroesophageal reflux disease and esophageal dilatation after a sleeve gastrectomy. As you can see on picture number B, the thickening of the esophageal mucosa due to the reflux and esophagitis. And when on picture number C, normally it's a dynamic image, of course, but you can see the contrast stasis in the esophagus. This is a picture of pouch dilatation after Roux-en-Y gastric bypass. Also a very enlarged pouch at the second wide arrowhead, which results in contrast stasis. This is a really interesting complication, because how do we know how big that pouch is? How many dilatation is there? So I looked it up in PubMed, and there's a quite newer technique with 3D imaging, multi-slice computed tomography, which basically means it's a very detailed computed tomography with multiple slices, very small ones, which can be reconstructed in a 3D visual assessment of your pouch after your Roux-en-Y gastric bypass. And these pictures look like this. The orange part, I think it is the dilated pouch, and we can measure with this 3D technique how much volume is in that pouch and how big it is. And the problem is, of course, we can also do an endoscopy and estimate how large our pouch is. But with an endoscopy, we can also directly intervene in terms of do we need to do a biopsy? Do we need an can we do an endoscopic procedure? But it can give a less precise estimate of our pouch volume, which can be more precisely assessed with a 3D volumetric CT scan. Just one study to elucidate this matter. This is a study of Arnolter, which was published in SORT in 2020, and they compared gastroscopy with the 3D multiple slice CT scan and looked at intrathoracic migration of the pouch after Roux-en-Y gastric bypass, and also looked at pouch volumes. These were the baseline characteristics of all the patients that were included. And what is interesting is when you compare the assessment of the median pouch volume, as you can see in table 2, both gastroscopy and the volumetric CT scan indicated that it's basically the same. So that's good. What was surprising for me to read is that in terms of intrathoracic pouch migration, gastroscopy didn't find any migrations, while at a 3D volumetric scan, 20 of 30 patients were found to have the pouch migrated into the thoracic cavity. And that's interesting because that's maybe the most important point of the whole imaging studies is you need to take into account the possible benefits and downsides of an imaging modality, and what can we do to get optimal imaging. And sometimes it needs to, sometimes we need to combine 2 imaging modalities, for example, a gastroscopy and a CT scan, and so on, of course, depending on the surgeon's discretion. So in conclusion, there are more ways that lead to Rome or somewhere else. And in every patient, you need to keep applying the basic principles. What kind of symptoms do we have? Do we need to visualize what the problem is? And how do we do that? And finally, what can we form as a surgical or even an endoscopical solution? And final point, every imaging modality has its pros and cons, which need to be considered in every patient, not only in bariatric surgery. Thank you very much. Apologies for the technical delay, but hopefully this was much better. Thank you.
Thank you, Dr. Pauwels.
Yeah. So I can introduce my last not least, my friend Cătălin Cupescu from Romania. He has a very special, interesting topic, how to prevent surgery complications. And he has a long experience. He's a coordinator, medical director in Bucharest in Romania, in the capital of Romania. And he's the president of the Romanian Association for Endoscopic Surgery. Maybe many can remember, for the EAS Congress, also in Bucharest. Yeah, and he's professor at University also in Bucharest. And Cătălin, very nice to see you. And it's very interesting, yeah, how to prevent, not to treat, how to prevent surgical complications. It's your turn.
Thank you very much for this kind introduction, Rudy, Rachel. Thank you very much for this. Thank you for the kind invitation, Rui. Congratulations to Clinical San Antonio for your successful conference. And I will be happy to share with you some thoughts in respect with complications. I am in a second sharing the screen, and I think you have it. Let me reduce the images here. It should be now well. Now, I'm sure you are not expecting from me to give you all the secrets of how to prevent complications. It is impossible, because it's not only an action, it's a process. Of course, within this process, there are a lot of actions, but it's an institutional project, and there are many tasks behind the preventing of the complications. And one is behind this STEMS, and congratulations, Rui, for your JCI accreditation, which is part of a process of the basis of the process to reduce complications. In bariatric surgery, we have surgical or metabolic and medical complications related to different procedures or related to different specific morbidity of the patient. And we know that we have a lot of complications, low rate of each other. But if we look together to all these complications that might affect the evolution of our patients, we can be worried about. This is a 5 years ago meta-analysis. It is true that it's searching on the first decade or after 2000, this 2003, 2012. Maybe we had that at that time more complications, but it's bringing an image, 17% overall complications with a mortality that is low, 0.8 in the first months, higher later on because the hospital can prolong the life of a complicated case, and a significant rate of reoperations. Maybe this is not meaning that much, but if you put this with 800,000 procedures per year, we are thinking about thousands of patients that might die and a lot of reoperations and complications. So no need to argue further. We don't want to see bleedings. We don't want to see occlusions, as you can see here. This is after gastric bypass, and it's almost died bowel, and fistulas that are difficult to treat. These are complications. Or portal thrombosis, looking like in this picture inside of the abdomen, or you see the picture, the CT scan, and the relevance of the imaging has been underlined previously by Sejak very, very nicely. So we don't want to see this. So we need to have a system to prevent the complications. And this is an institutional setup. And of course, issues to improve the complicated cases, because as soon as we got the complications, we need to early detect and then to properly manage those cases. There is a strong connection between prevention and early detection, because monitoring, following up, and prompt evaluation of a patient that you are monitoring and you see that something is not good with this evolution, that means a sort of prevention and early detection of something that is going to be a complicated situation for the patient. So there is a strong connection between this, not just performing the surgery and then bye-bye, I'm moving in another city, the patient is flying away. So monitoring is essential. And then when the complication occur, as it is a new disease, needs a proper diagnostic and proper treatment. And remember that any complicated case may affect the entire bariatric program you are involved in. No need to argue more, that we need to prevent. And there are here in this slide 4 issues, 4 chapters of my talk. There's an institutional and operational setup for your bariatric and metabolic center. The preoperative assessment of a patient that is candidate for a surgery, in our case, revisional surgery, the intraoperative management, and the postoperative monitoring and follow-up. All this might influence the process of preventing complications. I will not insist in the first one, because I can expect that all, maybe most of those who are participating to this very interesting meeting do run bariatric programs in a well-organized fashion. And they do have the support of a multidisciplinary team and the institutional support. So I will not insist in this that much, beside the fact that you need to have expertise in running the program for revisional bariatric surgery. The preoperative assessment should be very wide in order to prevent the complications. And then specifically, data collecting for all the pathologies, not only the weight and the related problems of these patients. And then to try to consider how is the protocol to be offered to that very patient, and involving the multidisciplinary team to identify exactly the moment for the revisional surgery. And of course, checking about any details of the previous bariatric procedure, because if in most of the cases was not performed in your clinic, easy going back to the file of this patient and digging in the video files to see exactly what happened. So you need to extract a lot of data before not to be surprised in the surgery. This is part of the process of preventing. And then running, of course, a complete preoperative workup, starting with the classical barium swallow that can offer a lot of information. You see, these are supposed to be sleeves performed some years ago, and you know what you have to do when you want to revise. Then you upgrade to a CT scan with reconstruction to see the anatomy, to reveal the hiatal hernia and go further for endoscopy, pH metry, manometry. These are very important in order to prevent the complications of the operation. And then discuss with the patient. I will not insist. Alexander did very well in the first presentation. And then try to control all the comorbidities by the time of inviting the patient to the OR. And there are a lot of, especially the respiratory and the metabolic and the cardiovascular problems of these patients. In some of the cases, the nutritional issue of the patients is critical. So we don't have to think about a optimal revisional surgery without improving the nutritional status. And in some cases, especially in those who suffered for affected absorption, including chronic fistulas. It was discussed about the gastrobronchial fistulas. These patients are highly affected from nutritional point of view. Then they need the first surgical step to be a jejunostomy. We do perform in Roux-en-Y jejunostomy that is going to serve after the revisional surgery for some weeks if there is any complication, or you can go to the nasogastric version, which is not easy to be supported by the patients. But anyway, I am insisting in this process of preventing the complications. We are before the surgery now, and we need to select the bariatric procedure in order to rescue the previous one. And this is not easy. And we know that the rate of complication is highly supported by the reducing the complications by the appropriate selection of the bariatric procedure. And don't forget that you might have sometimes a step-by-step approach, which might be better for the patient. Of course, they do have important age, gender, previous surgeries, estimate time of surgery and surgeon's experience, a lot of medical problems. And if you look at these patients, that it's maybe a good patient to jump on the operating table. But if you lift up the clothes, you will see that there is a risk of infection, urinary infection, that is changing for you the process of one in anesthesia to step-by-step procedure in this very patient, starting with lipectomy. Or during the operation, you might see such a liver and you change your bypass option and do maximum sleeve, do the biopsy, or not even that one. When you perform the bariatric surgery, you might have the opportunity to prevent any complication by the management in the OR and offering the best adapted condition for that very patient. And of course, evaluating during the surgery the situations inside. And I will underline measuring the entire length of the small bowel to all the patients when you go for a revision surgery. In most of the cases, you might see a forest of adhesions there, and you need to prevent any of the complications that might be intraoperatively encountered. This is, yes, much rare to have an intraoperative complication than the postoperative ones, but the postoperative complications dig in the process of the intraoperative maneuvers. However, using the energy devices as less as possible and using the cold scissor is advisable for these revisional patients. This is gaining some time because you don't have smoke inside, and you will get easy into understanding the anatomy inside of a patient that has been operated before. And you progress, you understand, and then you decide what kind of procedure is exactly to be done. And then to answer to the question, of course, we need to prevent the main complications, which are leaks, peritonitis, bleedings, and obstructions. And whenever we use the instruments, we need to think about a potential ischemia, which is the recipe for the leak in the postoperative period, and using the stapling in an appropriate way adapted to the thickness of that stomach or the bowel. Imagine that it's revisional surgery, and you might use the black cartridge as in this image, and you wait a lot, but in the end, you see that it was not enough for a very sick tissue. So you don't have just to look, you have to overshoot it. This is preventing the potential complication. There is a question of time after the surgery when it occurs. Then we have the bleeding. The bleeding might occur after the surgery, and we can do during the surgery something. And this is rising up the blood pressure and look to the stepper line that is outside at the peritoneal aspect of your organ, or inside in the right-sided image. You're rising up the blood pressure, and then you go inside of the small bowel and rule out the entire stepper line, and you will see the bleeders. Of course, you will have maybe in 90% of the postoperative bleedings a rectorrhea or a endoluminal bleeding, but this is also affecting the postoperative course. Very rarely you might have a hemobezoar, you need to reoperate. And this is, of course, only 5 minutes of extending the time of surgery. You got the opportunity to prevent the postoperative bleeding of the patient. And then, of course, the operation is ready. You are happy that your result is wonderful, and you need to follow up the patient. And this is early mobilization. I will not underline what you already know. They are mandatory issues. They are not done by you. You are the surgeons, and you control the process. You direct the process, but someone else will do all this. And you have to double check that this is to be done. And then the patients do have a postoperative evolution without any complications. And I will underline the prophylaxis for the thrombosis that in our center is for at least 3 weeks and extended more. Of course, you need to observe anything that is abnormal. And here it's the connection between postoperative monitoring, preventing, and the complication, because anything that is wrong with the patient might be the trigger for your actions to prevent the complication. Underlining here the thrombosis, if the patient is not drinking well, or if you don't have any vital sign that is altered, or everything seems to be okay by the time of discharging, the X-ray might show that the patient will have a potential good evolution, or it will be the obstruction that will impair the evolution of the patient. And you need to do something at that third day after the surgery, not wait 10 days after with the thrombosis or a leak because of the obstruction. The follow-up program got no limit. The postoperative monitoring should be continued within the program. And of course, we should demonstrate disponibility to our patients to suspect that something is happening not good with this patient, and come inviting to your bariatric and metabolic center. And your high expertise will demonstrate that it's a complicated situation, or about to be complicated, and this is again following up and preventing the complication in the very patient. I will end with these principal ideas by saying that bariatric surgery procedures are increasing, and revisional surgery is increasing as well. Rui said that up to 50% in his activity last year. It was a delicate year, yes, of course, but it's increasing for sure. These patients are waiting for our surgical input. The complication rates are low, but altogether are to make us worry about, because some of them are life-threatening complications, and we need a prompt diagnostic and therapy for them. Preventing strategies are mandatory to be set up in any and every single center. It is a process. It's a challenging process. It's not an action that is performed by a brilliant surgeon that it's a one-man show in a OR. It's a multidisciplinary input, and please transmit to your members of your teams the gratitude of supporting our programs to be as successful that they are. Thank you very much for the opportunity to speak with you, and good luck.
Thank you very much, Katalin. And now we are a little bit delayed, but we will have enough time for discussion. And I will give over to Rachel. She has some questions from the chat, and then everybody has the option to ask more and more, but not more than a half hour. Rachel, please.
Yeah, we have 2 questions to Dr. Serra. Dr. Himpengs asked if you know the gastrojejunostomy anastomosis size at 5 years after TORRE. So do we know the follow-up of this reduction of the anastomosis? And also Dr. Viveiros asked to Dr. Serra, how do you choose between TORRE and ROSE? Sorry if I don't pronounce well these techniques. Dr. Serra, could you answer these 2 questions, please?
Of course, thank you for these questions. The final result after 5 years, the outcome of the suturing, the diameter that we saw about in these 5 years, the most important outcome is the result after 1 year. So after the technical success, what we achieve, the result after 1 year, is the most important issue for the follow-up at 5 years. And the diameter, the initial diameter after the procedure, it was around 8 millimeter in this paper. And the majority of the patients in the 5 years outcome had diameter less than 15 millimeters. But of course, in my practice, I see that the enlargement of the anastomosis still happens after this revisional endoscopic procedure. So I would say that about 1/3 can also have weight regain even after the endoscopy revisional procedure. And the second question, it was how I choose between both methods. My personal option, I tried in the beginning both. My option right now in the last years, it's the TOR. It's more friendly to use. The learning curve is also shortened. And I prefer this method because I use it also as primary endoscopic treatment for obesity. So I can use it for sleeve gastrectomy and also for the revisional. So in the last 4 years, it's my personal option is the TOR method.
Okay, thank you very much. We have another question in the chat. It's for Dr. Neymar. Dr. Octavio Viveiros asks, he says that success and failure in bariatric surgery varies according to the point of view of the surgeon, the patient, and family doctor. So how to approach the patient without comorbidities who have insufficient weight loss, but think their evolution is sufficient for their goal? So, Dr. Neymar, what do you think? The patient is satisfied, but we are not satisfied with the result?
But if we're not satisfied by the result, it's not important, because our main goal is to receive the metabolic health at first of all. It's bariatric surgery. In this case, it's a preventive surgery to prevent some problems with heart failure, with stroke or something else. And sure, if the patient okay with the result, it's very good. For example, in our practice, we speak with patients that we don't go to ideal weight. Our main idea is receive instrument for control the eating behavior and the control on obesity. And other goal, it's to receive benefits for health about different comorbidities, the diabetes, the different heart problems, and others. And I think it's okay for me, if I understand well the question.
So, yeah, thank you for your answer. But I would like to make the question again. Maybe Dr. Weiner, that has a lot of experience with this. What do you think about Dr. Neymar and Dr. Weiner about these patients that we offer sleeve gastrectomy as the first step of the procedure, and they lose the weight but not enough weight, and they are happy with this, but we see that they didn't achieve the goal of the comorbidities, that we know that they will need the surgery, but they don't want the surgery, the second surgery. How do you manage that?
We know that all the endoscopic options that we have at the moment are very nice tools for the patient, but not long-term effects. Yeah? This is a problem. We will not have a long maintenance. So we have some results papers. If you look for the authors or studies, these people who publish this long-term data are all related to our owners of the family, of this production line. Yeah? This is a problem. In our experience, endoscopy plays a more important role. But you know, for final results, you have only just the surgical options. We can repeat endoscopy, but maybe endoscopy plays also an important role. Maybe this is a question to David Serra. He was talking nice options for technical new developments for treating some postoperative changes, but the indication, for example, after sleeve is also that you have a development of Barrett's, for example. What is the recommendation to for the patients or for the doctors, home doctors, to send the patients back for upper endoscopy control after sleeve gastrectomy? After never 5 years, 7 years? Maybe a question to David.
In my unit, the protocol is 1 year after the procedure, just for routine, and we can have another timing if the patient presents with some complications. As you told, one of the issues with the after the sleeve is the reflux disease, and sometimes the first symptoms that the patient presents it's the symptoms of the reflux disease, and many times the first endoscopy revision is because of these symptoms, not for the standard complications that we talked before. But I think the reflux disease in the future, it will be another complication of these bariatric methods.
But you know that the development of Barrett is not related to symptoms.
No.
We have the data from Austria, and we see maybe it's a recommendation in our society is now to have, after 70 years, also without symptoms, to have endoscopic control of all sleeve patients. It's our recommendation at the moment. What do you think about it?
How many years after?
After 7 years. Also without any symptoms. There is a recommendation to have an endoscopic checkup after sleeve gastrectomy 7 years. Also without any symptoms.
Okay, it depends of the age of the patient, of course. If you are dealing with young patients, I think 5 years, it can be a nice timing. If you are dealing with patients after 50 years, I think the interval for routine must be shorter. So the age of the patient, I think it's important after the bariatric, and the workout after the surgery must be not only in symptoms but the age. I think it's an issue in this problem.
Okay, I would like to ask to Dr. Pauwels. He told us that the imagology is really important in the revisional surgery. I'd like to ask him if is there any cases in which do you think that we don't need the radiological study before a revisional surgery? If you think that the endoscopy can answer the same questions as the radiological study before this reduced surgery?
Good question. Yeah, what I do think, if you have the time to do imaging, do it. It gives you more information. And I think the only real urgent indication is patients who are in shock or need emergency surgery. That's, I think, the only reason to skip imaging studies and go directly to the OR. It's not necessarily a revision, but it's an urgent surgery. That's what I think.
If you remember, for the time we had the bending surgery, the conventional X-ray was a standard. But in our center, in the high volume center, the standard contrast medium X-ray plays no role anymore. If you have an indication for CT or CT imaging, yes. But the most important role has upper endoscopy in our experience. So the conventional, you know, if you're doing a sleeve, you have no information about the sleeve volume. If you have a stenosis, yes, you can see the dilatation. But you know, this nice pictures that we see with a three-dimensional CT scan is an option, but in some indications, yeah. But the upper endoscopy is growing up and growing. And in my experience, I believe it's the own field in the bariatric surgery. And in the high volume center, it should be established our own bariatric endoscopy. And it's very interesting to have the results if this bariatric surgeon doing the upper endoscopy or a gastroenterologist. The differences. For example, this sleeve migration into the chest. We have a completely another view on the problem. So if you know what is the distance from the teeth to the lower junction, and you look at for the preoperative finding, and then you look after, this is another topic. I believe we should educate also our younger surgeons in this field to perform the upper endoscopy by themselves, the surgeon.
So, as we're talking about the younger surgeons, I would like to address a question to Dr. Copescu, because he was talking about different variables that could affect the outcome of the operation. What do you think about the experience of the surgeon, the expertise of the team, and do we need to put some limit in that? So maybe you can answer, and also the other panelists. Do you think that we can put a limit in which kind of revisional surgery can do every surgeon depending on the expertise?
Well, these issues are to be commented for many decades. I mean, there are 25 years since the credentials of a bariatric surgeon has been discussed. And this is for primary surgery. And we know very well that for the revisional surgery, you need to have in the surgical team someone that has a significant experience in this respect. I mean, it can be a disaster if you only if you go to rescue a band, if it was migrated and you didn't. I'm trying to give a simple example. You have a patient with a simple gastric bending and you didn't explore before, so the preoperative assessment was limited. You don't know exactly that has been migrated. It was a slightly maybe minor bleeding some months ago, and you dig there to extract. You don't know that much. You don't know that maybe only endoscopy will be enough to rescue that patient, or to wait for many other months. We noticed that the lack of experience might go into disasters. And you can end up with a bleeding that can be life-threatening in such a patient. It was a simple operation, straightforward gastric bending, and something that you couldn't revise. And this is the same for a gastric sleeve, that very simple gastric sleeve that you don't know that much how to do it. Maybe you end up, but the results will be not good. You end up with peritonitis and leaks, the same for gastric bypass and so on. So I think that the centers should not, from the institutional point of view, the ethical board should not leave for the good sake of the bariatric community, these things to be happening at least for the revisional patients. In primary, maybe the worst outcome will be that they will do a larger sleeve and the patient will not have the outcomes you are waiting for. But this is not a complication. I would underline, because there has been discussed that weight regain is a complication. No, it's just a need for another tool or another step of a lifelong treatment that we need to apply. Maybe we can change the procedure to do a bypass or do a re-sleeve. Don't expect that there is one that it's controlling universally without um, any problems, the metabolic situation of the patients. So I think, yes, underline, there is a need for expertise, and our associations, our community, IFSO is saying this all the time. There is a need for education. However, we know that some of those who are performing do not participate to these wonderful meetings like this one organized by Rui and Clinica San Antonio. They are not coming to congresses. They are not listening to these advices. And this is why a lot of complications do happen. So yes, expertise is necessary for any professional specialty.
May I make a couple of questions, if you allow me? One for the Serra. Because we know that the endoscopic techniques that he told us are mainly about to reestablish the restriction. And we know that in bariatric, but mostly in metabolic surgery, restriction is not the future. We have different concepts about metabolic effects, about microbiome, bile acids, well, and new techniques. So, for instance, if we know that the surgical re-sleeve has not good outcomes and it's not recommended anymore, it's more or less consensual, how can we believe that an endoscopic re-sleeve can work? This is something that, but I won't discuss about that. This is something that you need to think a little bit about. What I would like to ask you, David, from you is what do you think about the treatment of the marginal ulcer with the Apollo technique that because it has been shown here yesterday by Dr. Paris Klaija, a nice series of 8 or 9 patients healed with this technique. That would be my first question.
Thank you, Rui. I don't believe either in revisional endoscopy after sleeve, so it's a common point. And about the second question, yes, there are short series using the Apollo system for this chronic problem that some patients present. And I think in the Apollo, we will present another option for the treatment of the ulcers. And I think in the next few years, it will be in these centers the first option in this chronic problem in some of our patients.
Okay, good. That's because it's really, I remember that Professor Weiner told me or read from him many years ago that revisional surgery had 5-fold more complications than primary surgery. It's more complex indeed. It was at time and it is even more nowadays. So we need more expertise, as Katalin was saying before, but we need also more tools, more logistics. And I would go back to Katalin because in revisional surgery, I think that one of the more important issues, he told us about that, is to preserve the vascularization of the tissues, to avoid hypoxia and ischemia. So, and I know that he has some opinion about that. Do you think that new tools like the ICG are fundamental for revisional surgery?
I think yes. At this moment, we don't know exactly what will be the place of this technology. We know for sure that we can prove that we did objectively everything that we could to preserve the vascularization of that segment of bowel of stomach. And it is a routine for us to use ICG for all revisional surgery. So it's a daily base of use. and we're getting understanding more and more, because yes, at the first point you might see that there is a gap there of ischemia, and then you may say, yes, but this you can see by colors. You are an experienced surgeon, and you will see that that is a little bit blue. So you can do even without ICG to do something. Yes, but you got the experience, and this cannot be objectively proven. And the young generation needs something that should be much easier to be objective. This is once. And then we learn that this is not only about the arterial perfusion, but it is also about washout. Because if the venous system is not draining very well the tissue, that you might have a problem later on with that very segment. So we understood that we need to look to this fluorescence, the indigo cyanin green action in the minutes after, and to see if everything gets back to the normal color under the infrared view. So I think that there will be a part of our programs in a nicely and friendly using system, just pressing a button like you do in DaVinci, just clutching and see exactly the other color. And yes, I think this is something very good. And we also use for complications.
Okay, thank you so much.
And in time. Thank you for the
Thank
question.
Thank you so much. And forgive me if I will put another question, but I don't want to waste the chance or the opportunity to ask Professor Rudolf Weiner. Sorry, because we are inverting the positions, but because I know that he's one of the surgeons that I know that have more experience about tridimensional CT and the importance of that radiologic tool in revisional surgery and in bariatric surgery in general. So, Professor Rudolf Weiner, can you comment about the importance of the 3D CT?
Especially to estimate the gastric volume. It's a very good option. This has importance for the sleeve, but also for the gastric bypass, because with the gas insufflation, what you are doing during this investigation, you are really expanding. And you see the difference. You can also, by doing the upper endoscopy, have a air insufflation, but it's not the same. And though it gives you very good, and you can detect, we saw, this was done maybe 12 years ago, so the differences on the volume of a sleeve just 4 days after surgery or 8 years later. So if you have an increase of the volume of more than 160 cc, and this is most caused by antrum dilatation, then it's the sleeve is failed, and you need another surgery. The re-sleeve is only just if the fundus was left in the primary procedure. So maybe, hopefully, Michel is not listening this session because he's a fan of re-sleeve. But the antrum re-sleeve, it's another good idea. If the sleeve is long and why the patient's regaining weight, you have to go to another procedure. In this case, you need more malabsorption, and the MGB or the SADI or the SASI or the other, all the doing the switch, but nobody's doing any more doing the switch. I stopped this, and so far this is a good idea to find the real indication.
But I feel that it's really difficult to establish the cut point in which you can say that the pouch is really dilated or pathological, and which is almost normal in the follow-up. Do you have any correlation between the weight gain and the size of the pouch with some cut point?
Yeah, the problem is the pouch itself, the diameter to the small intestine. This is the most important thing, because the alimentary tract is a unit. between the capacity of the esophagus with 150 cc, maybe a small gastric pouch, but then a dilated alimentary limb in the Roux-en-Y gastric bypass.
If I,
So you can see it in a CT X-ray, three-dimensional, where the upper part has a volume maybe more than 500. This is nearly like a normal stomach. So the barrier is a stoma. If the stoma is dilated, yes, you can do endoscopic revision. This can help for dumping. It helps very well, but not for, maybe for a long time. For weight regain, the patient after this reconstruction, he's losing a little bit more weight again, but it's not the same as before in the primary procedure. Restriction is just an idea, and maybe it needs a little bit more.
If I can just jump on it for 1 second, thank you also, Rudolf and Raquel. I think there is proven in literature there is a relationship between the size more of the gastric jejunostomy than the size of the pouch in terms of having more weight gain. Abu Dayyeh has shown a nice study, but it's not a black and white situation. You have an important overlap where you can see is the size is going down. You see a bit more percentage of weight gain, but if you see on a scattered plot diagram, you're going to see that still some patients with a small size are confronted with weight gain, where the opposite as well. So you cannot learn everything about those sizes. That is true.
Rui, can I ask a short question?
Yes.
Okay, it's questions maybe for all experts, but with a very short answer. Tell me, please, what do you think about indication for revisional surgery, but about weight regain, not about medical complication, about weight regain? What do you think? It must be more strictly that indication for primary surgery, and the patient must do more different process before they are going to revisional surgery or not?
Well, this is a very good question. This is a very good question. You know, the problem is you have to find the indication in a discussion with the patient. Finally, you will decide you will do it or not. And there's a wide range. It's easy if you have a recurrence of diabetes or something else, but maybe only just to perform a major surgery for 5 kilogram weight regain is not a good idea from our view, but the patient has a different view. So it's a discussion.
And I think that there is another question to consider. When the first technique failed, there must be several reasons. So you must find the reason because the first technique failed. Because if you don't, then the second technique will fail again. So many times there is no an anatomical problem. There is another type of problem. So you must study first, you must learn what is happening, and then you can have a better answer for the second technique, is my opinion. So maybe we are out of time.
That's it. I will say that we have now 8, 9, 10 minutes delay. So if you want to keep the schedule on time, we need to finish here. But we have the chance to discuss again in the second part of the session. And we are going now for our conference, our top conference. I appreciate a lot, and I would thank all the speakers and Raquel and Professor Rudolf, the previous intervention. And I would go for the conference. The conference is also about revisional surgery, but in a different point of view. What I would like to hear from our dear Bruno Dielmans is how to organize set up a center to do it properly, the revisional surgery. We know that a center is a model in Europe. It's probably the center with more experience. Sorry, I need to repeat everything. It was only then, okay. So I was saying that Bruno Tillmans has a center in Europe, in Bruges, where maybe the bigger one in Europe, very known. Everybody is going there to learn something about this topic. They operate about 1,400 cases a year, and a quarter of those cases are revisional ones. So he has a lot of experience. He's the CEO of the BariaLink company that we established under his guidance 4 years ago or 5 years ago. Of course, he's also the chief of the Department General Pediatric and Vascular Surgery in AZ Sint-Jan Bruges. He has also academic consult in the University of Jans. He was the vice president of the IFSO European chapter in 2014, and he's organizing always fellowships, surgeon to surgeons, clinical immersions, and so on. With every day, he has a lot of people into his OR learning with him. But mostly, he's a great guy, a great friend, and it's for me a great pleasure. And I couldn't fail to have him here to talk about this. So please, Bruno, tell me what are your secrets to build such a good revisional surgery center.
Thank you, Rui. That friendship is mutual, you know. That's important, you know that. We know each other already quite a lot of time. I mean, I've heard, you know, that you are suffering so much now in Portugal, you know, with the COVID pandemic back again. We are waiting for the third wave, but we are trying to postpone it as much as possible. I will try to share my screen if that's okay for you. Thank you anyway for this nice invitation. I mean, it's an honor, you know, to share some of those issues with you all. And indeed, you know, in due course of our experience, we evolved more and more to, you know, a bit a center of expertise. If I would say, we have to still stay humble, you know, in terms of primary surgery, but also revisional surgery. But did I build it up? No, not actively. It's all passively, you know. When you receive a bit more credits, by way of speaking, you're gonna receive more patients. But anyway, at the end, I will show you some hidden secrets, you know, to also business-wise, you know, you have to think as well. And it's one of the big issues of revisional surgery is, and I already heard it from Rudolf and from Katalin, you still keep track on the fact of not having complications. That is the still most critical issue. We are not dealing with oncologic surgery. We are dealing with obese and morbid obese patients. Back again, it's not acute life saving. So be humble in your ambitions. That's important. Anyway, if I would start, it's okay for you that I start. So everybody, thank you very much. Everybody knows a bit slide. It's from Luigi Anchiesani, where you can see the worldwide survey of bariatric surgical procedures in 2016. And there was a double increase between 2008 in total numbers to 2016, so on 8 years. But amazingly a bit, if you look to the revision surgical procedure, it was just, I was a bit amazed, 7%, which was not too much. And I looked to my type of surgical procedures, primary revisional surgical procedures and complications in 2009 and 2019. So with a span of 10 years, and you can see that we were doing 13% of revision surgeries in 2008, and it increased to 2019 with also some complications which could be considered as also revisional or at least correctional surgical procedure. But what is very interesting to look what type of revision procedures we're doing in 2009 and 2019 is completely different, just on the span of 10 years. In 2009, I think around 85% of the procedures were conversions from the pure restrictive procedures, VBZ to band to the gastric bypass or sometimes the sleeve. This radically changed in favor now of more than 50% of the revision surgical procedures from 2019 were revision for the gastric bypass. And I think it is explainable by the fact that if you see the evolution of the bariatric surgery, primary surgical procedure in our hospital, you see that we abandoned more or less the pure restrictive procedure in 2006, 2007. That was the purple line, the VBG, the band, the green line, in favor for the gastric bypass type room Y. And we picked up a bit later than other institutions the sleeve gastrectomy, as well as the omega loop gastric bypass. So this is certainly the explication why now, we're going to see a different type of revision surgical procedure. This is a very nice study. This is the extended SOS study. Everybody knows the Swedish obese subject study, but probably not that publication. It's from 2019 from the JAMA, where they looked really to the long-term results of those procedures that they did so many years ago. The mean follow-up was 19 years. And you can see that how longer you're going to do the follow-up, nicely shown in that study, how higher you're going to do, or the incidence of doing revision surgery is increasing. You can see here 40.7% revision surgery after a band, 28% after the VBG, vertical band gastroplasty, and still humble results in terms of gastric bypass failures, 7.5%. And what is, I think, very important, and we have to come to that initially a bit, we still see patients with a complication or a failed procedure as the band and the VBG from the past. And most of them are related indeed to the occurrence of complications. For the band, most of them were heart rate problems or motility problems, but for the VBG as well, the known gastric outlet obstruction, as well as in some old Mason gastroplasties, the gastric feature. So most of those patients are visiting in still with some complications, not only the gastric outlet obstruction, but certainly also reflux. And in doing those conversion procedures, nicely mentioned already previously, is that this is a nice publication from just 10 years ago from Guy Bernard Cardière. Everybody knows Guy Bernard, as well as Jacques Kimpers, where they did 100 secondary gastric bypasses after a band and after sleeve, after a vertical banded gastroplasty. And as you can see, they reported a leak rate at the gastrojejunostomy of an astonishing 12%, substantially higher than for the primary cases, which was still also relatively high, 4.4%. And you can see that the mainstay of the hospital was around 1 month. So seemingly secondary procedures are prone to having more complications. We reported 2019 and 2020 our experience in converting a VBG to a gastric bypass. I think a bit with the highest number, more than 300 of those patients. 1/3 of those were old Mason gastroplasties. And we all know that they are more tough because the operation was done by laparotomy. A Marlix must have been placed with quite a lot of cicatrization. And in those old ones, there was even not a separation of the staple lines, inducing much more gastric or a discontinuation of the staple line with a fistula as a result. And then 2/3 of those were the more laparoscopic version, the McLean, where a celastic ring has been used and a full separation of the staple line. But you could assume indeed the operative time as well as the conversion rate was a bit higher in the old Mason, but not the reoperation rate or the morbidity. They were happily a bit the same. And if we talk about doing a good procedure, we have to mention some technical issues where I am afraid not all surgeons are taking care as it has to be. For the old Mason, we always advise when you go for that, try to make a good gastric pouch. Just focus on making good gastric pouch. I've seen quite a lot of studies where they go even higher in trying to make an esophagojejunostomy. This is normally not necessary. Try to still leave some gastric pouch. And if that has been made, with the rest, you can deal relatively easy. You can do a hemifundectomy by certainly excising your old staple line. You can do it the same way. And if there would be too much cicatrization around the Marlix method have been played, just go underneath and do a formal subtotal gastrectomy. But back again, just focus in making a good gastric pouch and a good gastrojejunostomy. The rest is irrelevant. If you go to the McLean procedure, that's an easier one, because you just can, what you think, trim the gastric pouch, but still be careful. And that's probably one of the issues why sometimes leak rate that have been reported is too high. You sometimes have a old staple line, which is not always at the lateral border. Some of those pouches are dilated, but if you're gonna resize that here, you can see that they're going to be on the notch of your gastric resection. They're going to be a region which could devascularize. Sometimes you even have a curled staple line in front, the old one. And if you're going to think you're just going to resize that, the same could happen. This part will devascularize. So you have to really look, if you don't have ECG, We don't have it yet, but probably we're going to buy that. Be careful where you're going to make your section. If you're dealing with that, you have to go higher. Otherwise, this part could devascularize. You're not going to have a leak immediately, but after 2 or 3 days, you're going to jump into problems. Important. And if you look a bit to the results that we have reported, I'm just going to go down a bit here that I see that better. We reported our experience and we had a 0.3% leak rate, which I think is quite well. Also resulting in, I think, a very acceptable reoperation rate of 2.4%, just by taking care, I think, of technical details. If we come then to the conversion of the band to a gastric bypass, and we still prefer to go for the bypass for a lot of regions, it's not the topic of today, and not go for a sleeve. Here as well, if you see all the bands that have been converted to bypass, and we did already 1,500 nowadays, a lot of those had band-related complications together with insufficient weight loss, because a lot of those patients developed maladaptive eating and they were jumping into the sweets. Now, I really think it is critical, and I've just heard Alexander mentioning that as well. A preoperative assessment is very important in planning your surgical procedure. Here on the left side, you see, I would say, a more acute situation where the band has slipped and you see that big gastric pouch hanging over. This is not a good candidate to do a gastric bypass in first stage. You open the band, you remove the band. Here, it's also not an easy case where you can see there's a herniation of the gastric pouches, cranial of the band, and all got herniated inside the chest. Not easy to do a secondary procedure in one stage. And here, this is what is quite common, a band that is seemingly well located, but has not been successful. The reason is that the band has been placed too high. There is no gastric pouch just above that. It's just a vertebral one. This could not have worked quite well to have a band. Then I think it's important to do what I call the patient-tailored approach, 2-step to 1-step. There are some arguments to do it in 2 stages. First of all, less inflammation, better blood supply of the pouch, a normalization of the gastric pouch if there could be a pouch dilation. And 2 publications have mentioned less anastomotic stricture. But there are contra arguments. You have to do 2 operations and you're going to probably have more adhesions when you do that 2 stages. Now, the decision, I think, is completely depending on the learning curve of the surgeon and the location of the band. If the band is located high and not well placed, it's not going to be difficult. But when the band has been slipped and it's a big pouch, it's a bit more tedious because you probably have to make your transection of the stomach above the band. We never do anyway a 1 stage in case of a migrated band. We always try to remove that endolumina and do that 2nd stage. You can see a bit of evolution in our institution to do the 1-step conversion to a band, to a bypass, excluding the migrated band. And you see that in 2015, we reached to have a percentage of 98%. So it is feasible, you can manage to do so. Other key point messages in surgical technical details, just very quickly, we remove the band first. We have to completely undo the gastric structure up to the upper part where the band have been located dorsally as well. We have to cut the fibrotic ring to have a better passage, but we don't sell out everything. I don't think it's going to be necessary. What we try to establish is a normalization of the anatomy of the upper GI system. And then in constructing your pouch, don't come too close to the gastric tube itself. Tailor your staple height. If you go above the band, you have to use an upgrade staple height. Construct your gastric jejunostomy in healthy gastric tissue. This is one of the issues that we prefer to use a circular staple or a hand sewn, because with the linear one on the backside, sometimes you're going to cross different tissue thicknesses. And at the end, you can end into the esophagus, which is not the plan. And that's the reason we prefer those type of anastomosis. And here we had a report in our local paper. They asked me to have a paper on that 88.5 patients where the band was still in local, where you can see that we managed to have a very low, I would say, reintervention rate of 1.1%. We just had 1 perforation of the small bowel, not even a leak of the gastric jejunostomy or the GG anastomosis with the same clinical presentation, but all the rest was seemingly quite well. So good results. Now, what is now becoming much more common for sure, and I'll come to that, is a failed sleeve and a failed Roux-en-Y gastric bypass. And the good thing on doing a primary sleeve, everybody knows that if you have a failed weight issue of your sleeve, there are a lot of solutions you can offer your patient. And probably it's not the issue of today. The SADI procedure will probably become the best in dealing with pure weight gain, not regarding reflux, pure weight gain of a failed sleeve. It is substantially more challenging, and that's one of the drawbacks as a bypass, a primary procedure, if you are dealing with weight gain for a gastric bypass. They are not good, they are not fantastic good solutions to offer your patient. And if you look to the literature in terms of a failed gastric bypass, there is a lack of good data, lack of good research. We only see in the literature some localized experience of various bariatric centers with their own preference, by way of speaking. Different surgical procedures have been promoted, but no single method is superior in terms of having good weight loss and having no complications. And I think one of the important flaws and drawbacks of most of those papers, that no uniform, congruent or systematic analysis have been done of the reason of the failure. In most of those papers, you can see not an estimate or a summary of the radiological examination have been done, neither a dietary counseling and or a caloric measurement. And this is the reason that we always try to do a good caloric measurement of the patient. They have to write down everything what they eat and drink during 1 week. They have to send it over, and they have to do that honestly. They send it over to a dietitian who takes 1 hour, 1 hour and a half to do a good calculation. It's still an estimate, but more or less we know a bit what at stake. This patient is eating back again 1,853 kilocalories a day, which is a bit too much for a good, successful gastric bypass. So what can we offer then a patient who is confronted with a failed gastric bypass? And we are now much more reluctant to quickly go for a surgical procedure. If there is nothing abnormal anatomically or functionally, we really try to focus all our energy in improving the compliance of the patient. Behavior modification, dietary modification, and exercise promotion. And of those patients that are put in a program during 3 months, and if they do not comply, we send them to the neurosurgeon, by way of speaking, to have a new brain. We don't operate those patients anymore. And this is a very expensive procedure, believe me, to have a new brain. Anyway, so if they do comply, then I think there is a player to offer a surgical procedure. And I think very briefly, there are 2 surgical pathways. It's already been mentioned. Adding restriction, I think the vast majority are fitting for that, or adding malabsorption. You have the endoluminal techniques, nicely discussed previously. You have the gastrojejunal sleeve in resizing with or without a band. You have the laparoscopic adjustable band placement or non-adjustable band placement. And at the end, adding malabsorption, doing a distal gastric bypass, type Sugarman, not the type Rowling, forget it. Or the conversion to a duodenal switch or a SADI procedure on BariaLink. Dr. Torres has shown a fantastic conversion from a bypass to a SADI, but that's a difficult procedure, not for everybody. Anyway, we work with a treatment algorithm and we do quite a lot of revision of the bypass anyway. Just briefly, if there is any anatomical deformity, then I think you can straightforward go for a corrective surgical procedure. If there's a gastric fistula, or if the pouch have been left too redundant, which we sometimes see for secondary gastric bypasses, those patients probably not have fantastic weight loss from the start, then you can do a revision procedure straight away. But in the vast majority, we're going to see a more or less normal upper GI series. For those patients, we put them 3 months on the behavior modification. If they do comply, then I think we can offer a surgical procedure. If the patient have loss of restriction and the bypass is on the upper GI, but also during the operation, normal, okay, it is not arbitrary, but we try really to do an estimate. Then we put an adjustable band because there's no argument to do resizing. If the gastric pouch and or the gastrojejunectomy has dilated, then I think it's a good argument to do that gastrojejunal sleeve or just a candy cane resection or pouch resizing. But we certainly offer a non-adjustable band on top of that to prevent back again dilation, as shown in the literature. Only for those patients who have no loss of restriction, who are still quite well restricted and compliant, but are still very obese, then we're going to consider to a distalization, but leaving as a minimum of 4 meters of what is called total elemental limb length, so absorption capacity of the small bowel. You can see a bit the revision for failed gastric bypass. We did 112 cases in St. Jan 2019. You can see that 38% of those patients got a gastrojejunal sleeve with and without a non-adjustable band. The majority with a non-adjustable and 26% we put an adjustable bed. In 17% we completely constructed a new gastroenteroanastomosis. In 15% we did a distalization, and in 4% we combined a distalization with a gastrojejunal sleeve. Just before I would end, I'm just going to take some time in, because that was the question of Ruwe, you know, can you not give some advice or some tips and tricks, you know, in trying to have that expertise, etc. I think that in all circumstances, we have to try to do the right thing. Discuss and you prepare your case properly, mentioned by Dr. Niemark as well. In case of weight gain, multidisciplinary consultation with ethical consideration. And we always have to balance the estimated gain in weight loss and comorbidity control with the risk of serious complications. In case of complication, listen carefully to the complaints of the patient. You have to do the evaluation of your X-rays yourself and think logic. I'm going to give an example. I'm just going to put that away. Around 1 month ago, you know, they proposed here, they posted on Facebook a nice case of a complication after sleeve gastrectomy. And I'm just going to, you know, mention what has been done. 2 weeks ago, this patient got a sleeve gastrectomy elsewhere. This is the upper GI series, where you can see a huge dilation of the esophagus. They did an esophagoscopy, and what you can see, it was able to pass, but there was a kinking at the gastroentero, on the GJ junction. On the CT scan, nicely to see there's something here behind which is seemingly not normal. This is located into the chest. Now, then I could see in Facebook a lot of posts were coming in. I've also commented that as well. Some surgeons, just to see what options that have been suggested, esophageal manometry should be performed. Somebody else was saying CT volumetry as being the first. Another was saying, think to achalasia. That would be the most sudden onset of achalasia 2 weeks after sleeve gastrectomy without any problems before. Anyway, then, okay, I had a similar case. The treatment was 3 weekly balloon dilations in ascending pressure. Another one was saying I would start with putting a stent, then plan to do revision for a gastric bypass. Another one was saying, agree with the stent, as I stated previously. If the stent is removed, we're going to do a high resolution manometry to reassure that there is no achalasia. Back again, that achalasia. Another was saying partially covered stent for a few weeks might straighten it up. Now, if I look here a bit to the case itself and we look better to the upper GI series, no, that's not the case, you know, and that part, common sense is not so common. What is the problem here? And we have seen those cases quite frequently. The esophagus is dilated because the upper part of the sleeve got herniated and stuck into the hiatus esophageal. Here you can see nicely the line of the gastroesophageal junction. Here you can see some part of the stomach, which is inside the chest, incarcerated, not just seen on the CT scan anyway. And so the location of the obstruction is here at the level of the entrance into the abdomen at the hiatus esophageal. If there's a chorioplasty be done, yes or no, it can happen even without a chorioplasty. So that is the problem. So you can do all tests, etc. What is the treatment for that patient? You have to do laparoscopy. You have to do a correction of that. All the other suggestions are good a bit from academical point of view, but I'm afraid from a clinician, it's not going to be a proper solution. You have to offer a better procedure for that patient. So think logic, I think is still important. Second thing, think as an upper GI surgeon and not only as a bariatric surgeon. Don't look what is surgically feasible option, but what is the appropriate one. And do not only focus on making a good anatomical correction, but focus more a bit on the function outcome. How will be the food passage after your correction you did? How would GERD will react? Will it disappear or could it even aggravate afterwards? And do not ignore long-time side effects and complications. Important to take that as a message. Here I'm just going to show you all upper GI series of patients that I had to correct for bireflux after an OAGB. In some of the cases, you can see what a short pause that have been done. In other cases, the patients had important GERD before the surgery, and there was even a big hernia before the surgical procedure. So all of those complications, I would say, are preventable because the OHEB has not been a good solution for those patients. And we cannot blame Dr. Rutledge or Dr. Karbach, who was ever doing a good omega loop gastric bypass, because he nicely described that your pouch have to be a minimum of 12, 13 centimeters before you're going to make your gastrojejunal anastomosis. But still those things happen, are preventable. And I've heard Kathleen saying as well of education, this is a necessary thing, because this is a complication what I think is not defendable anymore, okay? Last but not least, have advanced laparoscopic surgical skills. I mean, this takes time, but know yourself and know your limits. Perform a careful dissection. Use sharp scissors. And sometimes I'm not willing to use those harmonic scalpels or whatever, because you could have a thermal injury, what you don't see when you do your dissection. Always question yourself, can I make a safe staple line transectional anastomosis? Be careful to leave a poor vascularized transected organ or anastomosis. Am I self-confidence to make in all circumstances a safe manual anastomosis as an esophagojejunostomy? This could be a dreadful situation. You have to have the skills and pull back on time. Just a quick example here, in doing a gastrojejunal sleeve for a failed gastric bypass, it's important to know how the anastomosis has been made. If it has been made with a circular one or Hansoon, you easily can do that gastrojejunal resection without any problem of the vascularity. But if the anastomosis have been made with a linear one, on the back side, you have that tongue-shaped spur, a triangle a bit of jejunum, which is going higher. If you're just going to blindly, as we did, blindly doing our resection, this part could finally devasculate. And I have just a short video of 20 seconds to show you that. Here we did that gastrojejunal sleeve, and you can see that at the end of the procedure, you see that bluish discolored part. Don't think it's a hematoma. That's not a hematoma. This is a part which is going to be less vascularized. You cannot lean on that. First 2 days, patient will be good, but then he will develop a contained problem, contained leak. So if you see that, don't lean on that with ECG. Certainly it will not be vascularized. Properly do a new gastric bypass. Always work on safety in that terms. That's it. And last but not least, that's my last slide, really, because certainly I'm not willing to take it too long. I have some hidden secrets that I would certainly share with you if you're really trying to build up something strongly. And they all could be summarized in not doing something. Not do all X as we order we do. I've never been very innovative in just implementing new procedure or new approaches. Gastric plication, ECG, looked very well, have been abundant, then back again a bit later, like the plication. We may not underestimate that poor results, is it in the media, is it in the social media, whatever, get much more attention than good ones. Secondly, do not focus on supranormal results. I'm not interested to have an excess rate of 110%, 120%. No, the better is the enemy of the good. And last but not least, it's related to that fact as well. Do not perform extremely difficult or risky procedures. As I said in the beginning, bariatric surgery is still not oncologic surgery. Where for a pancreatic cancer, you have to remove the last cell, do a portal vein reconstruction. We understand that. Not for bariatric surgery. It's not acute life-saving. And I will just end by thanking you all. Obrigado, obrigada, I don't know. Anyway, everybody's listening, and I would invite, and already Rui mentioned that briefly, to join us at BariaLink. This is an international web platform that we have started in 2016 with some distinguished guests and active participants that we have, like Rui, who is joining us, Alexander has joined us, and also Dr. Torres. So feel free to join us. It's going to be very interested initially as a passive participant, and later on you certainly can submit interesting cases if you're willing to have a good discussion on that part. Thank you very much. Thank you.
Thank you so much, Bruno. Brilliant. I suppose that your last slide is one of the hits of this meeting, because in the good sense, and not to be too ambitious and to be reasonable is very, very important in visional surgery. So we don't have time for questions. Thank you, Bruno, again. We go for a break for about 10 minutes. We are coming back at 5:25. Okay? Time for a coffee. Thank you to all. Meanwhile, you can look at the video about about Lusíada's group that Hugo is gonna run in a minute, and also Ricardo. And you can listen also to some good Portuguese music, even if for a couple of minutes.
It's with these hands and the hands of our 6,500 professionals that we've gotten to where we are today. And it's because of these hands that we've built a brand to be proud of. And that's why we communicate to our clients the message, it's good to be in good hands, your hands. In the hands of those who materialize our mission to help people live healthier lives and to help make the health system work better for everyone. You who dedicate your lives to the well-being of others. You who push yourselves every day to be there for the best and worst moments in the lives of our clients. And it's through you that we demonstrate our values and show our pride. Proud to be a point of reference for the quality of our services and safety of our patients. For the health experience we provide, for the technology we employ, and for supporting the communities to which we belong. It's with your dedicated, professional hands, hands that truly show that caring is in our nature, that we are proud to be Lusíadas. It's good to be in good hands, your hands.
for just $67.
Hugo, estamos por aí?
Sim, sim.
Podemos recomeçar. Ora bem. O Sr. António Torres está ali, o Dr. Prager também está ali. Quem vai apresentar é o Dr. Nasser Sakram, que... Nasser, are you there? He's there. Okay. So, welcome again. Thanks for being here still. And we are going to the second part of with some talks about revisional surgery. For the sake of time and to make possible the last session in the due time, I would ask speakers to keep and to be strict about the 12 minutes presentation. Otherwise, we don't have time. We'll not have time to listen to everybody that we want to listen. The topic is the same, and I will ask Professor Antonio Torres and Professor Gerhard Prager to share the session. I will present Professor Torres, that doesn't need presentation, but you know that he has been a president of SECO and also IFSO president, and still the chairman of the IFSO Board of Trustees. He's member of 28 national and international professional associations, and he is a professor by the Complutense University of Madrid. He's also a great guy, great friend, and very, very warm in his connections and with a big knowledge. Professor Gerhard Prager is also, I don't know how to define, a very kind man, very warm also. He taught me a lot of things. He's a scientist, as has been said yesterday. He has been the chair of the scientific committee of the IFSO and is nowadays the IFSO European chapter president. He works in Vienna in one of the best hospitals and is also in the University of Vienna. And he has been, of course, linked to his Austrian Society for Bariatric and Metabolic Surgery. So, Antonio and Gerhard, please take the session as you wish.
Okay, thank you, Rui. Hello, Gerard, how are you doing? It's a pleasure to co-moderate this session with you guys, sir. You know, thank you, Rui. You did a huge effort in putting together so huge guys, so huge speaker, and so huge attendance. Yeah. So for me, it's a privilege and an honor to be here, you know, I told you. And of course, you know, to share this moderation with Gerard. He's a good friend. He's our European chapter IFSO leader now, and he's doing an extraordinary job doing that. I would like to also to welcome him here, and I'd like to hear from him regarding, you know, his approach to this session, and I'd like to ask him to present, you know, the first speaker. It's going to be Dr. Nasser Sakran. You know, this session going to be focused on revisional surgery. So, Gerard, you know, your turn. You know, please let us know when you know your approach, and please introduce our mutual friend, Professor Nasser Sakran from Israel. Gerard, please go ahead.
Thank you, dear Rui, dear Antonio. Thanks a lot. It's fantastic to see so many friends here. And we jump immediately in to lose not more time. Our friend Nasser is the current president of the Israeli Society for Metabolic and Bariatric Surgery. He has a huge experience, not only with one anastomosis gastric bypass, but with all the other procedures. And he currently works in Haifa, Israel. He's clinical assistant professor of surgery at the Israel Institute of Technology and director of Bariatric Surgery Center of AMEC Medical Center, Afula, and more important, he's a real friend for many, many years. Nasser, please, the stage is yours. Nasser,
okay, I am with you. Dear friends, first of all, thank you all. Thank you, Rui. Thank you, Gerhard. Thank you, Antonio. I have again a tough topic because, you know, we don't have a lot of literature about revisional surgery after one anastomosis gastric bypass, but I will try to do my best. Okay, this is my conflict of interest. I am bariatric surgeon for a lot of years. This is my case mixed disclosure. Today I perform more and more one anastomosis, but also I perform Roux-en-Y, sleeve, SATI, and revisional surgery. We know that the number of bariatric surgery performed worldwide is increased now, and one anastomosis gastric bypass now is the third most commonly worldwide. This is for me great. Also, I can say that also in Israel, the one anastomosis gastric bypass now is the most common procedure. And we have here the IFSO global registry that we can see clearly that one anastomosis gastric bypass now it's about 4%, but in Israel it's 60%, in Europe it's more than 10%. Before I start about the revisional surgery, I want to talk about, you know, we said revisional, redo revisional, but we need to do that. We have three kinds of revisional surgery: the conversion, okay, corrective, and reversal. Okay, sometimes we make conversion, sometimes with some correction, and sometimes we make reversal at the and all what we see here. This is a revisional surgery. Okay, the OEGB, I said again that you said that Mahawar, they have a good revisional surgery after he published one paper, and the frequency of revisional surgery is 0.4, about 0.5. It's, you know, I believe it's more today, but this is really it's very, very, very low number. Again, Parman, in another review, we can see here that the complications like marginal ulcer is about 2.7, GERD 2%, anemia 7%, malnutrition 0.7, and a remission of GERD. Okay, another study that we have the position of OEGB, MGB by IFSO, that we can see here again that anastomic ulcer is 1.5, hypoalbuminemia 0.4, excess weight loss 0.25, and GERD is 0.19. Okay, and here we hear that the Al Khalifa have a publication of 15 years follow-up after OEGB, and we can see here that he compared OEGB with Roux-en-Y and sleeve, and we saw the malnutrition. It's after a OEGB, it's 2.5%. It's the more common than Roux-en-Y, or we have that in sleeve is null. Weight regain, it's 0.5, okay, and malnutrition we can see, and anemia, it's 1.4. And if we see that we need to make some correction at some redo for this kind of patient. And before I want to talk what's the options, okay, maybe because what happened to us after this kind of operation, some surgeon make a very, very narrow gastric tube or very short common channel. And if we have very short common channel, it's like a short bowel syndrome that may have poor resorption of bile salts, low protein resorption, and reduction of intake of fat and vitamins, and diminished appetite. What's the causes of all this kind of revision after one anastomosis gastric bypass? Okay, again, Bruno Dillemans talk about that, but I will talk about again that some surgeons make a very short gastric pouch. This is not one anastomosis, this Roux-en-Y. They make a very long biliopancreatic limb. This is the most common reason. After that, we can have another intractable bile reflux, chronic marginal ulcer, anastomotic leak. Like every procedure, we can have leaks, stenosis, internal hernia, and excessive weight loss and malnutrition. It's special for a malabsorptive procedure. Hossain published 9,900 cases about one OEGB in United Kingdom, and you can see here clearly that the patient, they can have diarrhea, and he performed, he shortening the biliopancreatic limb. GERD, he convert to Roux-en-Y gastric bypass and make brown anastomosis. and protein malnutrition, he have one cases and he reversal to normal artery. You see that the revisional surgery can be a lot of options, but we will discuss about that. This is another publication, and I don't want to, because we don't have a lot of time, I want to talk about more the options. But again, we can see here that after why they convert to Roux-en-Y, it was the lot of them because malnutrition, this is the 55%, and another the 23 because marginal artery or anastomotic stenosis, and digestive disorders, it's again. This is the reasons, okay? Hussein have another publication and the same, he talk about diarrhea and about excess weight loss, and we see that he all the time tried to shortening the biliopancreatic limb. Mario, he had great complication, more than 2,067 patients, and a follow-up of 5 years. And we can see here that the, sorry. We can see here that the problem was GERD, anastomic stenosis, steatorrhea, internal hernia, gastric leak, weight regain. And again, this is the, he talked about the length of the pouch. Okay, he checked really everything. And we can see here that the most common, this is Mario publication, this is Lee, Carpaccio, and Cola. Here the GERD, you need that is about 4% with Mosella, but you see here the GERD, the Carbach, Chevalier, the marginal ulcer is the most common in. But you see that this is the most common marginal ulcer, GERD, and by reflux. Khalaj from I think from Iran, we talk about 189 patients and 7 patients after revisional surgery and 1 death. And we have more and more publication, but we see that or case report or video, multimedia articles or case series, because we don't have really a review. I think that this is the time to have a review, to collect and to have all this kind of publications. You see a more and more publication. You have videos, video case report, technical note, etc., etc. And now I want to talk that this is, I think, the options that we can have. Okay, I want to talk about surgery and about the options after a failed or after complication for a GB. Of course, we can have endoscopic some procedure, but we talk about the shortening the afferent loop. Okay, this is sometimes it's I know the patients, they don't like that, because the patient come to us because they suffering from really malnutrition, hypoalbuminemia, hypocalcemia, and they ask you, please, I need to have full anatomical reconstruction, and they don't agree to shortening, because also in shortening the afferent loop, we can have some complications. And okay, this is the shortening afferent loop. We can convert to Roux-en-Y. Brown anastomosis, this is for the bile reflux, not for the excess weight loss. Convergent sleeve, because some patients, they want to anatomical, full anatomical reversal, but they want something like a bariatric procedure. Okay, some publication, they talk about conversion to Magenstrasse and a full anatomical reconstruction. This is the option that I can talk. You see that Jenser, he talk about how to reverse the procedure, and he look it's look very easy, but really it's again a revisional surgery with more and more complications. This is my video about how to full anatomic reconstruction, and this patient have a hypovolemia, hypocalcemia, hypoalbuminemia, and he asked me to have a full reconstruction to reversal all the operation. See, you have see here the pouch, okay, and this is the remnant stomach. This is the bypass stomach, remnant stomach. It's here. And after that, we can make a gastrogastric. We don't have a lot of time. So here we see that we have gastrogastric anastomosis, and we can close the defect by, I use today a V-lock. It's only one layer, and that's all. Also, we can convert the one anastomosis to a Magenstrasse and Meal procedure. I don't like this kind of the operation because you can here leave a fundus, and we can convert to Roux-en-Y gastric bypass. You have here one publication about how they convert the mini to one anastomosis gastric bypass, and also we have by Himpans another technique how to convert one anastomosis to Roux-en-Y gastric bypass. Also, this patient asked me to convert the one anastomosis to sleeve gastrectomy. He don't want to reversal. It's again a sleeve after malabsorptive procedure. It will be, I think, not the best for the patient, but this is an option. Okay, here you see that this is the pouch, this is the remnant stomach. First, I reconnect the pouch with the bypass stomach, and now I ask the anesthesia to insert the bougie. I use the 36 French bougie, and after that, I start with the sleeve, like you see here, okay. And in the end, I need to close the defect. Also, I use the V-lock 30 one layer seromuscular. I use one layer continuous. When I want to conclude, I think the revisional surgery after OEGB, it's coming. We can see more and more, and this is the time to have a review about that, and I hope to start with that. Of course, the potential malabsorption and alkaline bile reflux remain a significant concern. We have a lot of problem about the malnutrition, bile reflux, and marginal ulcer. Okay, and we need to have a revisional surgery, and the patients undergo OEGB should be informed regarding the potential complications, that the OEGB have own complications. It's not like Roux-en-Y or SADI, because we can talk about the diarrhea, about the reflux, about the marginal ulcer. And it's really, I think we need to avoid short gastric pouch or long biliopancreatic pink. This is very important for us to do that, and to teach that for other, that this is what our problem, that we can see that the pouch are short, wide. Sometimes we can see that the biliopancreatic pink about 3 meters or more, and this patient can suffer from the complications. And thank you very much.
Okay, thank you. Dr. Sakran, Nasser, thank you so much. A very nice presentation. I think for the sake of time, I think, Gerard, I hope you agree that, going to be much better to maintain all the speakers live and to perform and to make the question at the end of the session. Do you agree, Gerard?
Definitely. Go on, please.
Yeah, I think, and Rui, do we have your permission?
Yep.
Yes,
Sure.
yes.
Yeah, I think, it's going to be much better, because there are even some concepts regarding revisional corrective surgery we can discuss with Nasser, these kind of items. So let me introduce the next speaker, my good friend, Mario Musella. I don't know if I have to introduce him in Spanish or in English or in Italian, because he speaks a fluent Spanish, because he was here training here in Madrid many years ago. Professor Mario Musella is associate professor now at the Federico II University at the Advanced Biomedical Science Department of Naples Medical School in Italy, and also is the president of the One Anastomosis Gastric Bypass Club and the member of many Italian and international societies, and is a very well known surgeon. So Mario, welcome to this session, and I ask you to talk us about the revisional surgery after gastric bypass, the Roux-en-Y gastric bypass. Mario, welcome, and the podium is yours.
Pues muchísimas gracias, Antonio. Bueno, vamos al inglés.
Okay, de acuerdo.
I am so happy to meet you all, and it's a pleasure for me. Thank you, Rui, for this invite, and thank you, Gerard, and thank you, Antonio. Well, let's see what we should do, or we have to do when the Roux-en-Y gastric bypass doesn't work. This is the title of my presentation. And well, this is my disclosure, and this is my case mix disclosure. And since the introduction that Alan Whitgrove made in 1994, it was clear that a Roux-en-Y gastric bypass had several ways to be performed, because it was not only laparoscopic presentation, but also the difference in the length of the pouch, or the length of the BP limb, or the length of the alimentary limb, the common limb, retrocolic, anticolic, antigastric, retrogastric. There were different ways to perform it, but I believe it is important to define, before we go into the reversal surgery for the Roux-en-Y gastric bypass, that the Roux-en-Y gastric bypass is much more restrictive, is a much more restrictive procedure than it is causing the one anastomosis gastric bypass that Nasser just commented to us. And in this slide, we have to consider that being a restrictive procedure, we have to behave consequently. So the greatest problem when the gastric bypass doesn't work is that we have a weight regain in a rate of patients that can reach the 20% of all operated patients. And this is an interesting study from George Fielding and his group. It was presented in 2015. It is interesting to see, we have a very interesting and long follow-up here, is longer than 10 years, that we have an excess weight loss rate that is around 59–60%. That is a good result for this surgery with a good remission of comorbidities. But the first thing we have to note is probably the greatest, the biggest Achilles heel that this surgery has is that we may meet a good rate of internal hernias, or following a small bowel obstruction. That is an important drawback of this surgery, because it can go underdiagnosed in most centers, especially is the patient goes into the centers in the emergency, and there's not bariatric surgeons available to understand what is happening. So this is a problem that we can have with the Roux-en-Y gastric bypass. And this is another interesting study remembering us why the Roux-en-Y gastric bypass is a respiratory procedure. And this is a study from Canada, from Nick Priestou, and he compared different limb lengths in super obese or morbid obese patients, 10 to 40 centimeters for shorter limbs and 10 centimeters for longer limbs. In morbid obese or super obese patients, as you can see, there was not so much difference by lengthening or shortening the limb of the bypass that lead us to understand to argue that probably this surgery is really more restrictive than the one anastomosis gastric bypass. Another revision, systematic review of 24 studies in which the Roux-en-Y gastric bypass was converted in different surgeries. In 5 studies, it was converted, was distalized, and in 5 cases was made a revision of the gastric pouch and the anastomosis. In 6 cases, in six studies, there was a revision by putting a band, or in this case a ring, of course. In 2 studies, it was revised to a BPD or a duodenal switch, and in 6 studies, we had the utilization of endoluminal procedures. And this is what they found, that basically the conversion from the Roux-en-Y gastric bypass to the BP limb, to the biliopancreatic diversion, was the most effective of all the conversion they found in their study. But of course, we have to consider that in any case, it was burdened by a higher rate of complication. And this is another interesting study in which this group evaluated 28 patients. This is more recent. Is studies from 2020, and they basically lengthened the BP limb, they distalized the bypass, or shortening the common limb, or using a part of the alimentary limb. But in both cases, those authors found, we can consider they were 28 patients. In 8 cases, that is almost 30%, they found hypoalbuminemia, proteic malnutrition. That is an interesting issue. We can find by lengthening the limb. And this is another issue we can have with the gastric bypass, that is the candy cane. The candy cane may present with different symptoms, that is pain, regurgitation, or vomiting, and weight regain. And in some cases, they can overlap, of course, all these symptoms. And it's interesting that the most common presentation is pain plus regurgitation or vomiting. And in this study, the most effective way to detect this problem was using a common barium swallow that was even most effective than endoscopy or CT scan. Again, another interesting study in which they've been compared the placing or the placement of ring around the gastric pouch of the bypass versus the revision into a BPD. And this is the time in which the revision surgery was performed, was in the first cases following Roux-en-Y in the basic group, 3 or more years, and even longer when the patients were revised to BPD. And in the end, what they found is that at the beginning, of course, the band was less effective. The BPD was much more effective. But at 2 years, the weight loss rate was very similar between the two two ways to reverse the bypass. So the banded bypass has acceptable results for additional weight loss, but can help patients suffering from dumping. And in very selected cases, BPD can achieve an additional weight loss, but with some complication, some more complication than we can find in the ring group. Another interesting paper in which they basically banded the pouch with a ring, with a non-adjustable ring. And what they found was interesting, because they found that when the bypass was working well, good, they were good responders. They had a good response even after placing the band in case of weight regain, of course, following some months or some years. While when the gastric bypass was not working so good, they have poor results even placing the ring around the gastric pouch. So in any case, the total body weight loss improved by 7 to 26% at 1 year. And this is interesting because the weight loss remained stable for the 2 following years. And in some cases, anyway, the rings is more than 20% had to be removed, most often due to dysphagia, also because these rings, as we know, were non-adjustable. And this is an issue we have to remember. Again, other option for converting the gastric bypass is the pouch reshaping, or the anastomosis resizing. This is a paper in which 26 patients after pouch reshaping for weight regain were treated in a university center, and they undergo a laparoscopic resection of the gastric pouch and of the anastomosis. And of course, they had some long-term complication, and in any case, they achieved good results even with the pouch reshaping and the anastomosis resizing. And this should be evaluated, of course. This is an interesting series from the United States, from HIGA, of course, and this is a reversal of the Roux-en-Y gastric bypass, in which cases we have to reverse this surgery. The case was due to marginal ulcers, or marginal ulcers and malnutrition alone, or chronic pain and nausea, or reactive hypoglycemia. That is an interesting and interesting problem following this kind of bypass. And this is what they found. And in general, all the reversal patients, following the revision they undergo, at the end, they set themselves around a 26.4 of BMI, and following of the reversal from the previous gastric bypass surgery. Another interesting systematic review from our friends from Pakistan, and this is an interesting review in which a good number of gastric bypass was revised, and for weight regain, of course. And this is the rate and in which different revisional procedures were used. 19% was used an adjustable or non-adjustable gastric banding. In more than 9% of cases was used the BPDDS or SADIS. In some cases, the diastylization with or without the band or ring was used, or in some cases, the endoscopic treatment was used, or a laparoscopic or intestinal anastomosis was resized. Was the most common cases, was more than 26%. And this is the etiology of weight regain, basically pouch dilatation, and a larger gastric pouch, anastomosis dilatation, wide gastrojejunal stoma, and so on. And basically, this is the results they got in this systematic review that stated that basically the distalization was the most effective of all the kind of surgery used. And of course, other malabsorptive procedures, BPD or SATIS, got good results, but with an higher complication rate. And finally, to go to conclusion, and other interesting study in which also a conservative medical approach was used. This is liraglutide, that it was used in some patients in this study, and the patient was received or liraglutide or endosurgery with Apollos, or the implantation of a Fobi ring with a pouch resizing. And in the end, these are the results they got. In the end, compared with revisional surgery, liraglutide was a low risk and resulted in important improvement in hypertension and the dyslipidemia. Therefore, they suggest, of course, to use sometimes this conservative approach. So, in conclusion, the non-adjustable gastric band improves the weight loss, but there is a high rate of removal. The pouch reshaping improves the weight loss, but there is a high complication rate. The reversal is indicated for malnutrition, of course, but it's not easy to do. The elongation or conversion to other malabsorptive procedures is effective, but there's a certain risk of malnutrition. And other medical approach are interesting and probably should be explored and investigated in the forthcoming future. So thank you so much for your attention.
Thank you, Mario. Gerard?
Thank you very much, Mario. I think we make the discussion at the very end. So we immediately go to our next speaker, which again wouldn't need any introduction. Mohit Bhandari is a maximum high volume surgeon. He's founder chief surgeon at Mohak Bariatrics and Robotics in Indore, India, and he has a huge experience not only with primary procedures but with all the revisional procedures. He's an expert in seals, laparoscopic surgery, and I am looking forward to hear your talk. Mohit, please, the stage is yours.
Hi, good evening, everybody. And I'll just start my presentation. I know that we are running late, so I would like to immediately start my presentation without any further delays. So I'm asked to talk about revisional surgery after sleeve gastrectomy, and I think that's the writing on the wall. I think all of us know that this is one of the surgeries which we're going to revise the most in coming future, and that's what I've been asked to talk about. So I bring greetings from Indore. This is my center. I'm now a vice chair at the Sri Aurobindo Medical School and the university, along with the training center, the hands-on training center and the animal lab, and the director of Mohak Bariatric and Robotic Surgery Center. These are my disclosures. I work with Professor Fobi, who is also the founding president of Bariatric Corporations, and plus I'm a consultant to Bariatric Solution and Dr. Fobi's company. So please judge my lecture in the light of my disclosures. We have done close to 15,000 bariatric procedures. And what I would want to say here is that sleeve gastrectomy, as far as we are concerned, we never thought that it was a standalone operation. It came as a stage 1 operation for duodenal switch and biliopancreatic diversion, and a significant number of patients do not lose adequate weight after sleeve. They also develop de novo GERD and hiatus, and most of the patients with this GERD can have Barrett's esophagus with dilatation of sleeve tubes. So the point I'm trying to make here is that sleeve gastrectomy was not a primary surgery which we are trying to use it as, and that's why we are suffering at the hands of it. It was a surgery which would require a second stage operation later on, and that needs to be converted into either a duodenal switch or a biliopancreatic diversion or maybe a gastric bypass. Now, this is the story. After 2009, we have a huge surge in the number of sleeves. So what do we see at our center? If we are doing a 380 sleeves per year, and that's the amount of other cases we are doing, you can imagine that the number of sleeves which we would be revising every year would be close to around 30%. And that's what is happening. Now, what can be the causes for revising these sleeves? A 30% rate of sleeve revision is quite high. I listened to Mario and a couple of speakers before. But the surgery I'm dealing with is sleeve gastrectomy, and you can understand that that's a surgery which is too prone to have these revisions, just like an adjustable gastric band. If not equal, a little bit less, but yes, a good chunk, 30% of them are exposed to revisions. The patient-specific causes can be presence of a psychiatric disorder, physical inactivity, use of some medications that can cause weight regain, endocrinopathies or non-compliance or eating disorders. That's what we're gonna get when we have surgeons who do sleeve gastrectomy in the grab of doing something called as a greater curvectomy. I would say it's my own term, but these are so-called pseudo bariatric surgeons who are GI surgeons, but they want to do the bariatric because they want to add this to their armamentarium. Rather than doing something which is very good for the patient, they just try to do this surgery, and then they have mechanical issues where they leave a large fundus or a large antrum or a large body of stomach, and then it fails. At the same time, if we go and see, we need to evaluate these patients, understand their pre-surgical status, the surgery which was performed, the weight loss trajectory, the dietary history, and the medication. But what I would want to say is that once we evaluate these patients by radiology, we have to understand that we are going to face this 30% rate, come what may, even if we are doing almost perfect sleeves, which means that we have metabolic failures after sleeve gastrectomy. And these can be, ranging from technical to physiological to psychological to anything in sleeve gastrectomy. The problem is the economic impact of this weight regain, which is tremendous. Caroline published on it. They say that it's a 15,000 to 25,000 extra US dollars. I would say it's different for different countries. In India now we have insurance paying in, but still the insurance paying in for the revision bariatric procedures for sleeve weight regains is still out of question. Now, how do we manage these sleeves? So we have different ways of managing them. At our center, we usually manage them by an algorithm, which Professor Phoebe set in for all of us, and we've been practicing with him for the last 4 years now. So it's very simple, and all of you can understand it. Those with adequate weight loss but de novo GERD, absolutely a gastric bypass. A de novo GERD, a gastric bypass. Those with inadequate weight loss, without a de novo GERD, we might revise it to several different procedures. We may do a banded gastric bypass or a mini gastric bypass, or we may re-sleeve it and band it. And those with adequate weight loss and weight regain, those are the cases which also we have that do good weight loss with the sleeve, but have started to regain the weight, can again be exposed to all these procedures. But the point I'm trying to make it, if you have a de novo GERD, the gastric bypass still remains the treatment of choice, and that is the most subset of patients we find. This is a complicated algorithm, but what I basically said before is that, GERD would be exposed to gastric bypass. That's what I'm going to say. I'm not going to go into all these details, but I'm going to put it simple. These are some of the revision procedures we did at our center. So you can see we can revise a failed sleeve to a banded gastric bypass. Obviously, these are not the cases where you can, go ahead and directly start to do like a primary case. Just as this, we had a lot of additions here. You can see this sleeve is pretty much dilated. Now, I'm happy when I see these kind of sleeves. I can tell you, you can go ahead and do anything here, and this is going to work. These are simple cases. You have a large pouch there. You go ahead, you do a banded gastric bypass. You go ahead, you do a re-sleeve. Everything is going to work here because this is a technically failed sleeve where surgeon left a large amount of fundus, and now you can see that even the short gastrics are not mobilized properly. So then we go ahead and do this job. Here in this case, because this patient had some GERD, we had to convert it into a banded gastric bypass. I'm just going to fast forward with video. You can see that this, I'm creating a pouch. And when I create a pouch, I resect a lot of this pouch. So that's what I do. And that's what gives fantastic results. You can see here. Then we put a non-adjustable band. Mario talked a lot about these. He says there is a 30% removal rate. I for sure have not that high a removal rate. It's around 2 to 5% in our series. And the reason is that this ring is not very tight. You can see that despite a bougie inside the pouch, the ring is lying loose over the pouch, and we are trying to, do the Gastro J. Rest all these steps are the same. I'm not going to go into the details. We have to do a roux anastomosis, close the internal hernia defect, like we always do. And then once we close these defects, we have to do a Gastro J. But the point I'm trying to make it that the ring lies absolutely loose on the pouch, and that I can demonstrate here. This is the Gastro J which we do, and at the end of it, now once we have closed this defect, you can see that the ring is lying loose on the pouch. So here is the ring. You can see that there's a big defect here between the ring and the pouch, and then you can see the bougie will come in and you can have this nice. Also, all these revisions close both these spaces, just like primary surgery, both the Peterson space and the internal hernia space after the jejunostomy. So that's very important, because these surgeries, if done with proper protocols, will not have complications and all those issues. So that's the revision. You can have a revision of failed sleeve to a re-sleeve with a band. Now this is something which was controversial, but we have done more than 30 cases now. This is a sleeve which is dilated. Again, you can do anything here and get away with it, because this is a good dilated sleeve. So I'm going to re-sleeve it, but now you can see that this sleeve, interestingly, is dilated more in the body and then in the fundus. So there is some part which is not that dilated and the other part. So you see a lot of dilatation here in the fundus, but less in the antrum and a part of the body. So what I'm going to do is I'm going to do selective resection and the placement of a non-adjustable band. Now this is not done in the past, but we did 30 such cases, and I'll present my data here if I get some time. I have very limited time here. So you can see there is non-uniform dilatation here. Now we are addressing a very important issue. So I'm going to resect this pouch in a different way. I'm not going to resect the entire sleeve, but taking care of the fundus, and then I go 3 to 4 centimeters below the gastroesophageal junction, place in this minimizer ring, which I use nowadays by Bariatric Solution, a fantastic ring that can be arranged and calibrated to its size on the table. And then we do a re-sleeve with placement of the minimizer ring. So, what I want to say is that this is a different procedure, and the results are gratifying because we have a dilated fundus there. We have a good amount of area which is resectable. So these are not tough cases to manage. The problem would occur when we have cases where you don't have a sort of a very dilated fundus. Now this case, we converted the sleeve into a mini gastric bypass. Again, very dilated fundus, a technically flawed sleeve I received from some other center, and patient almost regained, if not all, most of his weight. Again, you can go ahead and do anything. Here we did a mini gastric bypass, but as you see, all my cases, I resect my pouch. I just don't go and attach a loop of the bowel to all these pouches. We have to, make sure that these pouches are calibrated to their length, and then we go ahead. Here I did a banded mini gastric bypass, which is again a different procedure, which usually surgeons would not do, but we have a good amount of experience with this procedure. And then we do this anastomosis here. And then finally, the anatomy looks like this. This is an endoscopy, which we perform later on to just check that both the loops are patent. And we do intraoperative endoscopies a lot. I'm very fond of it. I've published a lot of data on it. So that's the procedure. So sleeve, if the pouch is dilated, you have a lot of options. Now, this is something very interesting, which, most surgeons would not do, but Manuel met me in 2014, and we started to do tightening of these sleeves by endoscopy. You can see this is a large dilated sleeve on the gastrographin study, and I'm very used to do this procedure. In fact, after the COVID-19 pandemic, I received a dozen of these patients from all parts of the world, I would say, where we have to revise these dilated sleeves by endoscopy. This is done as a daycare procedure at our center. We call the patient inside, admit them in the morning, and by the evening we discharge them. And I can do these procedures in 15, 20 minutes, and we can, tighten these sleeves up and add liraglutide, as Mario said. Mario said that liraglutide, if you add, it's a good procedure. I would say add liraglutide in conjunction with bariatric endoscopy. So use all your procedures for bariatric endoscopy in association with the medical management like liraglutide. Now we have semaglutide, which is available, and that's the Ozempic injection which we use. It's a weekly injection instead of liraglutide, which we had to give daily. So we are using this. We call most of the sleeve weight regains, and there are a lot of them across the world. You talk about it and you get a sleeve regain patient, weight regain patient. We do them, add a Ozempic injection a week and give them the entire thing. And then we get something like this, which is a tight tube, just like a sleeve gastrectomy with gratifying results. So we have done 45 or 50 of such procedures, and now we publish that data, but now we are doing this quite a regular basis. Again, just to mention, these procedures can be converted to SADIs. I'm not going to go into the details of this, but just to let you know that this is one of those cases where you can give a good amount of malabsorption. But again, as I said, I always re-sleeve my pouch, because they are those cases where I get better results as compared to just doing. And this is the anastomosis with the first part of the duodenum. A little tricky here, but we do a lot of SAJ. We call them SAJI rather than SADI in India, because we leave a good 350 centimeters of a common channel. And what we call them as single anastomosis jejunal-ileal bypasses, which we perform a lot here in India, and they are pretty good in terms of revising these failed sleeves. A lot of these patients are there. I'm not going to go into the details of it, but what I would say is that we are usually now doing preemptive management. So I heard my health minister this morning. He said the best way out in 2021 for every specialty in medicine is be preventive. So let's do something where we don't need to do revisions. Now, what we can do for sleeves? Maybe we do banded sleeves, and when we do these banded sleeves, we create a perigastric window, put a band 3 to 4 centimeters below the esophagogastric junction. Now, this may sound to be very commercial to most of the surgeons behind, but there is science behind banded sleeve gastrectomy. I published 6-year data in SORD, and Dr. Fobi introduced this concept. And we are seeing some very gratifying results here. The restriction of the small pouch is maintained. There is early satiety, and there is forced compliance. This is our data from Mohawk, which is published in SORD. We have a 36.28% of total weight loss with banded sleeves, and these are the primary banded sleeves. So you see there's no weight regain here, and you see that the weight loss peaks it up, but then it stabilizes. But if you have a normal sleeve, this trajectory would have come down, and the weight loss would have come down to around 50% with failures. So you see, we have some problems here. We have a little bit of anemia. We have a little bit of albumin deficiency. A good amount of vitamin D deficiency. But the point is that the quality of life is still better in most of these patients as compared to malabsorptive procedures. Minimal leak rates. These are the comparative studies. So what I would say in conclusion is that banded sleeves are the way where we can prevent the cost of the revision surgery, and they are huge. As you can see, we have compared both of them, and there is also a cost to endoscopic removal of these rings. So thank you very much for giving me this opportunity. This is my team. At the end, I would say that we are offering various treatment modalities for obesity at center, but they are determined by the profile of the patient, guided by the findings from the analysis of our own data, which is prospectively maintained, audited, and published in literature. Thank you very much for this opportunity.
Thank you very much, Mohit, for that excellent talk. I think I give the word immediately to Antonio to come to our last speaker. Antonio.
Okay, perfect. Thank you, Gerard. Let's introduce Dr. Eidos Godoy. He's a titular member of the Brazilian Society for Bariatric Metabolic Surgery. He's a very friend, as the current president of the chapter of the Rio Grande do Norte. And also is a member of the Brazilian College of Digestive Surgery, and he's the coordinator of the Surgical Center of the University Hospital Onofre Lopez of the Federal University of Rio Grande do Norte. He's talking about the regional surgery after transit by partition. It's going to be a very challenging talk. So Eudes, it's your turn. you know, the podium is yours. Welcome.
Thank you very much. I want to be the first to speak in our beautiful Portuguese language, okay?
That's perfect.
Perfect, perfect.
Muito obrigado, meu amigo Rui, pelo convite. É um prazer imenso estar aqui dividindo experiências com tão seletos experts do mundo inteiro. Nós vamos falar de um conceito um pouco diferente do que vem sendo discutido até o momento aqui na mesa. E esse conceito se baseia em um princípio diferente, em explorar um princípio diferente nas nossas cirurgias bariátricas e metabólicas. Os conceitos clássicos de restrição e má absorção não são mais os únicos responsáveis pelos resultados das nossas cirurgias, seja para perda de peso, seja para controle glicêmico, controle das comorbidades metabólicas. Nós sabemos hoje que existe claramente uma série de players, de novos agentes, de novos mecanismos responsáveis por uma verdadeira neuromodulação que pode agir causando modificações metabólicas que, de certa forma, independem de uma restrição exagerada e, principalmente, de malabsorção. Embora essa operação tenha nascido com uma filosofia diferente, ela não foi simplesmente uma modificação de um duodenal switch na ideia inicial do Dr. Santoro, mas nós podemos dizer que, de forma prática, nós simplesmente mudamos o local da anastomose ileal, fazendo com que haja a preservação da via natural de saída gástrica, mas obtendo efeitos neurohormonais importantes através de um estímulo precoce e intenso do ilho, principalmente de sua porção mais terminal, e mantendo a via de saída normal, o acesso ao trato digestivo superior, minimizando os efeitos de malabsorção. Portanto, é uma ideia diferente, é uma intenção diferente dos critérios clássicos de restrição e má absorção. Essa operação, portanto, para nós, ela tem o que se pode fazer de melhor em termos de componente gástrico e o que se pode fazer de melhor ao componente intestinal. Nós buscamos estímulo neurohormonal intestinal do intestino distal, nos parece que essa operação é a melhor configuração para que nós possamos obter os melhores resultados. Uma crítica que se faz, uma preocupação que se tem com relação a essa operação é o fato de nós não termos o controle exato do que passa pela anastomose e do que passa pelo duodeno. Isso é, apesar de ser um fato, nós temos uma estimativa, e é bom que seja assim, que 70% do fluxo alimentar vai para o ilho pela gastroenteroanastomose e 30% aproximadamente pelo duodeno, desde que se tenha alguns cuidados com relação à distância do piloro, a preservação de um segmento de antro e um calibre adequado da gastroenteroanastomose, além, evidentemente, da importância nas consequências nutricionais da disposição do tamanho das alças. De forma que, do ponto de vista de cirurgia revisional pós esse procedimento, nós temos, de maneira geral, pensamos em indicação por perda de peso insuficiente, mas também, e certamente nesse momento mais frequentemente, por algumas complicações características das derivações biliopancreáticas, que também pode acontecer com esse tipo de procedimento, principalmente quando esses cuidados técnicos não são observados, como eu comentei no slide anterior. Se nós pensamos em aumentar a potência no que se diz respeito à perda de peso, induzir uma perda de peso adicional, a princípio, nos resta a alternativa de convertê-la numa operação tradicionalmente mal absortiva, particularmente hoje em dia, pela popularidade e pelos resultados melhores na literatura, num duodenosuíte clássico ou numa bypass gástrico de anastomose única. Na verdade, nós entendemos que o que se pode fazer de melhor, como eu comentei, de estímulo neurohormonal, nós já conseguimos com uma bipartição, de forma que nós acrescentaríamos apenas malnutrição, um componente malabsortivo, que no nosso entendimento poderia causar mais prejuízos do que benefícios nesse momento. Apesar de nós não termos estudos comparativos bem feitos, nos sugerem que essa
Penso que estamos a ter alguma questão de ligação.
Problemas da rede.
Não.
Ele está a falar, não consegue ouvir. Eudes, está com problema de internet, o sinal deve estar fraco, não estamos ouvindo.
Maybe we go for the discussion if we have lost him, and if he comes back, he could continue the second part of his talk.
Pode continuar. Se calhar é melhor.
Do you agree?
Okay, everybody agreeing on that?
Yes, so, Antonio, let's go to that solution.
I'd like to start, asking to the different panelists, different speakers. Yeah, we are focused on surgery, but what about what to do before indicated revisional surgery when a procedure fails? I mean, what do you do, guys, before indicated a revisional procedure? What do you do regarding that? Dr. Sakran, Dr. Musella, and Dr. Bandari, what do you do before indication, when you directly indicated reoperate the patient? Sakran?
Yeah, because I said that the revisional surgery, if the problem, we need before to again ask the patient to perform all the all the exams like ultrasound, upper UGI test, and gastroscopy. We send him to dietitians from 3 to 6 times, and we talk with them about all the options. This is what I all the time say, that bariatric surgeon or revision that perform revision, he needs to know that he can have more than one option. Okay, I can't say that bariatric surgeon, he can perform only one revisional surgery. He needs to know how to convert sleeve to Roux-en-Y to sleeve to one anastomosis or SADI or etc. etc. And he needs to discuss with the patient, because we know that the outcome, the patient, they need only to have only weight loss, but sometimes to talk to them, it's not enough weight loss, because you can suffer from diarrhea, malnutrition, etc. etc. And this is what I say, you need to talk with the patient, and we must choose the best option for the patient.
Yeah, and what about you, Mario? How many of your patients do you put on medication before thinking in reoperating them?
Sure, of course, as Nasser was commenting, we have two need for regional surgery. The first one is for weight regain, of course, and the second case is for long-term complication you can have following one anastomosis or one wire or sleeve or whatever. In my experience, I always try to solve the problem without surgery at the beginning. For example, if I have problems of reflux or I don't know, some gastric pain that may mean that the patients have an ulcer in the classic bypass or on one anastomosis gastric bypass, I try to resolve the problem in a conservative way. Later, if I see that the situation doesn't improve, of course, you have to solve this with surgery. My personal experience, you know, I am very honest. I'm not very familiar, for example, with primary Roux-en-Y gastric bypass. I almost always do the one anastomosis, but I must admit that, for example, the Roux-en-Y gastric bypass is an extraordinary conversion from one anastomosis if the patient has some reflux. It's an excellent conversion solution.
Okay, how about you, Mohit? You know, you are a huge number. Give us some number regarding the percentage of patients that coming to you for revisional surgery and you don't do that on them. How is the percentage of you don't reoperate it and you put them on medication or, you know, change lifestyle and so on?
So Antonio, I beg to differ from Mario and all others. I offer a revision surgery to 100% of my patients. I don't think diet works.
I knew that, Mohit. I knew that. This is the reason I'm asking you.
100%, 100%. I don't think the diet works. I don't think anything works. I don't refer them to dietitian. I don't waste their time. I offer them either an endoscopy. You know, I do offer them a medical management like liraglutide, as we said, or maybe a semaglutide, which is a weekly injection, but I don't send them to a dietitian and waste their time. I think it does not work. We have to understand that for a patient, primary surgery did not what we do here. I don't agree. I absolutely offer them a revision. I think we are ethically bound to do that. And we do that as per our algorithm. As I said, you can offer them anything from endoscopy to SADI. And on that, I agree with Nasir that you should have multiple approach in your armamentarium. So I offer 100% of bariatric surgery with some medical management, obviously. Combined, but not alone.
Yeah, sure. So Gerard, can we come back to Dr. Euden regarding that, or is he ready?
Yes.
Yes.
Eudis is back.
Okay.
Okay, I'm back. I'm ready now.
Let's go, Eudis. Go ahead.
Perdi minha conexão, desculpa, mas agora parece que a coisa já normalizou. Bom, então eu dizia que esses procedimentos, embora nunca tenham sido comparados de uma forma adequada, nós temos evidências de estudos observacionais que nos sugerem que são procedimentos de resultados similares, de forma que nós não temos evidência suficiente para apoiar a conversão de uma gastrectomia vertical com bipartição intestinal, onde nós não encontramos alterações anatômicas que justifiquem, em um outro procedimento do tipo malabsortivo, em virtude de nós estarmos adicionando riscos sem termos nenhuma evidência de que nós vamos ter realmente ganho do ponto de vista de perda de peso opcional. De forma a justificar um pouco melhor essa nossa posição e no sentido de apoiar e de entendermos um pouco melhor o porquê que nós temos que ter alguns cuidados quando revisamos dessa forma por complicações relacionadas a sintomas intestinais ou desnutrição, eu gostaria de discutir um pouco alguns conceitos recentes que nos fazem pensar que é possível entender de uma forma diferente a disposição das alças intestinais, buscando resultados diferentes de puramente má absorção. A primeira pergunta que nós fazemos é se há realmente algum efeito primário desses segmentos de alças, diferente, portanto, da questão de uma maior ou menor malabsorção. Alguns estudos mostram que, com relação a controle glicêmico, há uma atividade suposta de proteínas que podem levar à resistência insulínica, mas nós não temos nenhuma evidência de que isso tenha impacto no resultado em termos de perda de peso. Estudos de um grupo japonês mostraram que quanto maior a alça biliopancreática num bypass, melhores são os resultados em termos de perda de peso e de controle metabólico. E de forma interessante, quando essa alça biliopancreática era ressecada, esses efeitos se perdiam, sugerindo um papel primário para essa alça biliopancreática, para esse segmento excluso. Esse mesmo grupo, posteriormente, mostrou que acontece uma alteração tanto na composição como nos níveis séricos de ácidos biliares, e que esses ácidos biliares reduzem sua concentração ao longo da alça biliopancreática, mostrando um papel primário da alça biliopancreática no metabolismo dos ácidos biliares. Portanto, haveria progressivamente uma concentração menor de ácidos biliares. Isso é estranho, porque nós sabemos que é no ilho terminal que os ácidos biliares são absorvidos na sua maioria, e que estudos experimentais fazendo um bypass biliar, com colecisto ileoanastomose, simulam os resultados observados numa operação, por exemplo, de um bypass gástrico. Portanto, é de se estranhar que, com a concentração menor de ácidos biliares no ilho terminal, possa ter algum efeito primário. Dito isso, parece algo que não nos traz convicção buscarmos uma adição de oclusão intestinal, de exclusão intestinal, de um componente malabsortivo para essa operação, em virtude do fato de que não há nenhuma previsão, mesmo do ponto de vista mecanístico, de que isso possa cursar com benefício metabólico. Dessa forma, para nós, na nossa opinião, nós não temos indicado nenhum procedimento revisional para uma operação de gastrectomia vertical com bipartição do trânsito intestinal para ganharmos peso adicional, por falência de perda de peso. O que, para nós, quando isso acontece, significa que é chegado o limite que nós podemos conseguir com essas operações. Cirurgia bariátrica tem limite, e para nós, uma gastrectomia vertical com bipartição do trânsito intestinal, bem feita, sem alterações anatômicas, parece que caracteriza realmente esse limite. Uma situação importante, como eu citei anteriormente, é quando nós precisamos revisar por complicações relacionadas ao bypass intestinal. Perda de peso excessiva, flatulência, diarreia ou desnutrição proteica. Na verdade, volta a chamar a atenção para a importância dos detalhes anatômicos, da distância do piloro da anastomose, do próprio calibre e também da preservação do segmento de antro para que haja uma distribuição de fluxo adequada com a operação. Porém, mesmo tomando esses cuidados, em algumas vezes, nós temos o desenvolvimento desse tipo de complicações. E aí, tentando resolver, evitar ainda mais a ocorrência dessas complicações, que já são menores do que numa operação do duodeno suíte clássico, na nossa impressão, e principalmente na experiência do pai dessa ideia, o Dr. Santoro, ele fez um reposicionamento da enteroanastomose no sentido de aumentar o canal comum. Esperava que houvesse uma redução da eficácia da operação em termos de perda de peso. Mas qual não foi a surpresa quando, analisando retrospectivamente sua casuística, observou que, ao invés disso, os pacientes que tinham um canal comum maior apresentavam, pelo contrário, até uma perda de peso melhor, associada a um melhor efeito do ponto de vista de ocorrência de sintomas intestinais e de eventual má nutrição. Isso gerou, então, para nós uma hipótese de que o ilho, para ter um melhor estímulo neuroendócrino, para ter uma melhor função neuroendócrina, ele precisa estar com todos os seus componentes. Nós chamamos, então, a hipótese do holoílium, onde um canal comum maior, desde que com alimento e com bile, ele passa a gerar estímulos neuroendócrinos melhores, e isso suplanta a perda de potência que nós esperávamos com a redução de má absorção. Para que a gente possa entender um pouco melhor isso, rapidamente, é importante a gente lembrar que a célula enteroendócrina precisa de nutriente para que seja estimulada para a liberação dos seus enterohormônios. De forma mais interessante, nós sabemos hoje que não adianta só o contato do nutriente com a face apical da célula. É preciso que ele seja efetivamente absorvido. Portanto, eu preciso ter nutriente hidrolisado na luz e eu preciso ter a absorção para que eu tenha a secreção desses enterohormônios. Além disso, isso não acontece só com glicose, por exemplo. Isso acontece com ácidos graxos, isso acontece também com a própria ação dos sais biliares. Eles precisam ser absorvidos para que na membrana basolateral eles estimulem os seus receptores e que levem, em última análise, as alterações metabólicas que nós queremos obter. Uma palavrinha em especial para a ação dos ácidos biliares, porque eles parecem importantes nessa hipótese. Para que os ácidos biliares conjugados sejam absorvidos, é preciso que nós tenhamos a ação dos transportadores apicais de sais biliares na membrana luminal do enterócito. Absorvidos, eles vão estimular um receptor nuclear, que na verdade é um fator de transcrição, FXR, e que vai, por fim, levar à produção de um fator de crescimento fibroblasto 19, FGF19, que tem várias ações metabólicas importantes. Além disso, agora na célula enteroendócrina, através da absorção desses sais biliares, na membrana basolateral também, estimula um receptor TGR5 que vai levar à liberação de enterohormônios, principalmente GLP-1 e PYY. Portanto, é preciso que o ilho terminal seja exposto à bile, aos sais biliares, para que haja a mobilização e o estímulo desses receptores na produção, principalmente de FGF e PYY e GLP-1. Isso é importante porque o FGF19 está claramente associado a várias melhorias metabólicas, tanto em termos de controle glicêmico, como em termos de modulação do gasto energético e principalmente da redução da ingestão calórica, levando a um controle mais adequado de peso a nível nos centros controladores do hipotálamo. Isso é importante também porque nós sabemos do bypass que essa alça alimentar ela é hipertrofiada pela presença de nutrientes não digeridos na sua luz. Isso é uma coisa que preocupa, porque pode estar associada a um aumento da capacidade absortiva e uma redução da eficácia da operação a longo prazo. Agora, se isso acontece numa alça de ilho, o que vai acontecer é que esse aumento do fluxo de nutriente para o ilho vai levar a uma hipertrofia agora do ilho, que, exposto mais precocemente e numa quantidade maior aos ácidos biliares, por ter os receptores, os transportadores apicais de sais biliares, vão promover uma absorção mais importante, e isso poderia explicar o que o Dr. Santoro observou num estudo randomizado em pacientes diabéticos submetidos à bipartição intestinal versus tratamento clínico, além de um resultado contundente muito melhor do grupo cirúrgico, uma hipercorreção dos níveis séricos de FGF. Portanto, fechando a explicação para essa teoria e justificando a revisão quando há sintomas intestinais, diarreia e ou malnutrição proteica, eventualmente, a extensão do canal comum, ao invés de reduzir a eficácia da operação, pode, na verdade, aumentar a eficácia da modulação neuroendócrina do ilho. Portanto, ao nosso ponto de vista, é a forma mais adequada de fazer essa cirurgia de forma primária ou de revisá-la quando nós temos complicações com efeitos adversos intestinais ou desnutrição. Talvez uma alça alimentar menor para que nós tenhamos um canal comum maior seja o racional para os resultados melhores e o ganho da popularidade da versão em alça ou em única anastomose, também da bipartição intestinal. E isso, um canal comum maior, protegendo contra efeitos adversos e contra desnutrição, banhado de bile, para que haja uma modulação por sais biliares adequada, tanto do ponto de vista de secreção de enteropeptídeos como de FGF-19, poderiam explicar os resultados bons ou até melhores com as versões em anastomose única das várias operações que nós dispomos atualmente. Era isso, perdão mais uma vez pelo contratempo da perda de conexão, e eu fico à disposição para as discussões posteriormente. Muito obrigado.
Muito obrigado, Eudes. I think, Gerard, come back to you to continue with the discussion. Mr. Prager?
Yeah, thank you for that interesting talk. Unfortunately, I couldn't hear parts of it, but nevertheless, let me take the opportunity and ask some questions to our speakers. Let's start with Nasser. Nasser, you mentioned the length of the tube. What is the minimum numbers, and maybe also to Mario a question, the minimum number of 60 millimeter cartridges you use to perform an adequate pouch in OAGB?
To talk about the length or about the what kind of tube I use?
No, the length. Just the length to prevent
the length for me, it's about 15 centimeters. Yeah, we have some consensus that more than 12, but I try 15 and sometimes more. This is the minimum for me today, 15 centimeters.
Oh, sorry, the question was the minimum number of 60 millimeter cartridges you use, not the length of the pouch. What is the minimum number of 60 millimeter cartridges you use?
Okay, 3.
3. Did you ever scope the length of your pouch?
Yeah, I tried in the first to try what for me, because 6 is not 6, you know that. But the 3, it must be 18, but it's not 18. It's about 15 or 12.
I can promise you that it is much less. Mohit, what do you say?
I use 6 cartridges to make my pouch. If you are using 3 cartridges to make your pouch, the length of your pouch is 10 centimeters.
Well,
no, sorry, I talk about the vertical, not about the horizontal.
Just the vertical.
I said 3 for the minimum for the vertical, okay, not for the it's minimum 4 if you talk about the horizontal.
Gerard, even for vertical, I would require at least 5 to 6.
Yes, but 5 to 6 is really a lot. I mean, I usually started in former times with 3. Now I regularly use 4, but I scope all my patients, as you, Mohit, intraoperatively, and even with 4, the pouch length is not 15 centimeters.
Oh, and it's less than 15, absolutely.
If you want to use 6 cartridges, you must start at the pylorus.
Yes.
If I can, well, just a comment. When I start by doing the pouch, I get into the antrum. My pouch at the end is J-shaped, is not vertical. So following the first cartridge that is quite vertical, or I never use less than 6 cartridges, but never less than 6, never.
And I would support that, because my rule is do it as long as you can. So, and 6, sometimes 7, sometimes 5. Something is different, but as long as you can.
Okay,
but
I have another question.
Do you agree, guys? So, remember, it doesn't matter the number. They're going to be much more challenging to perform a longer pouch. I mean, if you go closer to the pylorus, the dissection of the lesser curvature is going to be more challenging for many surgeons, because it's not as easier to do the dissection there than to go a little higher. Do you agree on that?
Well, I want to make a point here, Antonio. I would say you use 4 cartridges, 3, 10, 12, whatever you do, or whatever length of pouch you make. If the bile has to come to the esophagus, it comes because of the problem with the lower esophageal sphincter and not the length of your pouch. The last day, Mario was there with me in a virtual bariatric university, and he would agree. We had a pouch of 18 centimeters in a mini gastric bypass, and the bile was in the esophagus. So pardon me, I endoscope all my patient, and we find bile in the esophagus in a pouch length as high as 18 centimeters. So you can make a very long pouch, that's beautiful, but it's not going to prevent a bile reflux if you have a defective lower esophageal sphincter.
Sure.
Yes, but Mohit, we are going to have more restriction if you have a longer pouch, and that's important also.
Yeah, we need a narrow tube. We need a narrow tube with a wide anastomosis. That's fine, but you know.
I believe that Mohit made a good point. I believe it's not only a matter of length. We should imagine the esophagus and the gastric pouch as they're moving. They're not frigid structures. They're flowing down. We have peristalsis. So it is important. I believe that it's not only a matter of length. Of course, the longer you tailor your pouch, the better it is. But it's not only a matter of length. I agree.
You know, a very important point, you know, listening all your comments, you are a very honest guy, you know. My view from outside, because I'm not doing one somatic passes, you are very honest, guys. But we have to admit that any procedure, I mean, sleeve, Roux-en-Y, one anastomosis gastric bypass, SADIS, BPD, we have to face with some problems. And we have to face with some patients that are not doing well. I think the most important message to take home to the audience in this last session. You know, we have to deal. You know, there is no an ideal technique. You know, because our disease we are fighting against is a very complex disease.
I agree definitely.
Yeah, I have a question to Eudes. Eudes, I have a question to you, sir. What do you consider going to be the role or the place of the transit bipartition as a primary or as a revisional surgery? Do you think going to be the same? What going to be the percentage of patients you submit to transit bipartition as one step of as a revisional? What is the role of this procedure as a revisional? What is your opinion about that?
Quando eu indico a bipartição do trânsito intestinal, não é?
Bom, yeah, I mean, what is the role of this procedure as first or unique procedure or as a second step after failed sleeve or whatever you want, or banding or...
Okay, I perform transit bipartition as a revisional procedure after failures after sleeve and gastric bypass. Is my favorite revisional procedure in both situations. I do not increase restriction or include malabsorption in any of these operations. Of course, we have some malabsorption with transit bipartition too, especially when we don't take care in that technical aspects that I said in my presentation. The gastroenteroanastomosis shouldn't be so large, 3 centimeters in length in maximum. And we have now a different disposition, conformation of the biliary, common and alimentary limbs, as I shown, because we don't have malabsorption. In the primary procedure, I perform in super obese patients, and I perform too in diabetic patients, especially mainly in severe diabetic patients with difficult control, is my advice for the patient. Diabetic with difficulty in medical control, super obese, and as revisional procedure, after sleeve and after gastric bypass.
Thank you, Gerard.
Well, I think there are many other questions, maybe to address the bile reflux after OAGB. So Nasser very nicely pointed out a really low rate that's given in the literature, somewhere between 0 and 1%. My question to all of you is, do you think that this increases with time so that we see a low rate, let's say 0 to 2-3% in the first 3-4 years, but in the long-term run, when we see a certain dilatation of the pouch, as we see it also after sleeve gastrectomy, is there an increase of bile reflux? Mario, Nasser, Mohit?
Sorry, Gerard, I do not get, I was losing the
Sorry.
the
So
audio.
with the OAGB,
Yeah.
in the long-term run, you will see a certain degree of dilatation of your pouch, right?
Yes.
It's assumed because it's a rather narrow and very long pouch. So the same fate as with the sleeve gastrectomy, or at least comparable. So I would assume, and that's what I see in the long-term run, I see an increase in symptomatic bile reflux. And I wanted to ask you whether you see the same or not.
Well, in my experience, it is a little bit different. There's some difference between the sleeve dilatation you see, because the sleeve is in a high pressure system in which you have a higher, you have the lower esophageal sphincter and the pylorus. In the mini gastric bypass or one anastomosis, you have you don't have the pylorus, so it is less exposed to higher pressure. So it is a little bit different. But in any case, in some cases, I see the dilatation of the pouch, of course. And in these cases, I found some ulcers, some problems related to gastric pain or epigastric pain. And scoping these patients, I found some ulcers.
Because, you know, the argument that it's a low pressure system, I'm not sure whether this is really so valid. Because when we look, now there is a big concern about migration to the posterior mediastinum after sleeve gastrectomy. And we started doing 3D CT scans. And you see very nicely the staple line in the posterior mediastinum. When you go and look at your Roux-en-Y gastric bypasses, which should be also low pressure systems, you will be astonished how often also in the Roux-en-Y your pouch is in the posterior mediastinum. And these are often those patients after Roux-en-Y who suffer from symptomatic reflux. So I fear, to be honest, that even in the OAGB, we will end up with some patients suffering from bile reflux in the long-term run, because we see a certain degree of migration to the posterior mediastinum. This is my experience, and I started doing the OAGB in 2011, but maybe I'm doing a bad job again. The same was true for the sleeve. I can remember when I started talking about reflux after sleeve, I was bashed by the sleeve fanboys for claiming that. So story repeats.
Yes, this is correct. I agree absolutely. But I believe that the key point we have to realize we are dealing with obese patients, or those patients have a high abdominal pressure. And a lot of them, almost 50%, have a dilatation of the hiatus is quietly unavoidable. So I believe that the key to have a correct surgical indication is the preoperative study. As Bruno Dillemans was remembering us in his presentation, when you find a hiatal hernia or some reflux, it is not a good indication for the one anastomosis gastric bypass. I absolutely agree. So you have to explore your patients before, to see if they have some hiatal dilatation, and to repair it if it is the case, whether you go for a Roux-en-Y or for one anastomosis or for a sleeve.
I fully agree, Mario. The problem is that these de novo hiatal hernia migrations occur post-operatively. Also, you have had no hiatal hernia before. And this occurs in sleeve up to 40%. Yes. And I can promise you that it's a considerable number also after Roux-en-Y gastric bypass.
Sure.
Saying that, but I don't know how to prevent it, unfortunately.
Yeah. Yeah, this is a good point,
In
Gerard,
my
but
opinion,
I'm not sure that all bariatric surgeons study
in my-
their patients correctly.
No, in my opinion, the only way of preventing is not operating the patient. Once you touch the hiatus, you are, pro to do that. It's the only way. No, I'm kidding you a little bit, Gerard. But that, I really think about that.
I think your point is valid. There are surgeons who claim if there is no real bigger hernia, a smaller hernia, you should not touch the hiatus. So saying that, I'm not sure. I don't have the stone of wisdom. I think nobody has. So we need more studies on that.
I absolutely agree.
Gerard, just a point to make here. I think Mario said very correctly. First, preoperatively, let's rule out the GERD. Let's do a good pH manometry and let's do a good endoscopy preoperatively and don't operate, just like a cult, do mini gastric bypass for everybody. No, if you have a GERD here, don't do a mini gastric bypass. The second is, you very correctly said, I have a lot of these patients with gastric bypass who have GERD now. So you are absolutely correct. We do something with that anatomy that it creates GERD. Bariatric surgery causes GERD. We create that anatomy. So I think the best thing is, let's all start to do endoscopy. Let's endoscope these patients. The point here is that most of these GERDs can be asymptomatic. Most of these reflux, can be asymptomatic. And that's where the problem is, that whether they are really causing the changes in the lower end of the esophagus. So we need to biopsy it, need to see and follow. So endoscopy is the key. All of us should start doing endoscopy post-operatively for all our patients rather than being dependent on a gastroenterologist, is my message,
My friends, I would ask
a little bit about, even taking into account all the revisional talks we have had today, just to come back to the principle. We are coming back now to perform the correct indication at the first time for the proper patient. Because if we fail in doing that, we will face with a very challenging cases. I mean, fail Roux-en-Y, fail sleeve, fail one anastomosis gastric bypass. In my opinion, we have to deal with this before performing the first procedure, because if we don't do our work correctly, we are lost.
Yes.
Even performing a Roux-en-Y gastric bypass is in a patient very heavy, or to perform a one anastomosis bypass in a patient with GERD, of performing a sleeve in a patient with Barrett esophagus, low pressure of the lower esophageal sphincter. I think we have to focus in the patient at the beginning, not to indicate very easily a procedure in every patient. I think we have to focus on that for avoiding to have to face with these challenging revisional surgery procedures.
Totally agree.
Gerard, any comment?
I think this was almost a wonderful last word. But let's ask.
Yeah.
Okay,
I'm sorry, but we need to finish.
Do you want us to say something? I'll come into you to close this session, this outstanding meeting, Rui. Congratulations. In a loud voice, you did a huge effort, but it was worthwhile. Congratulations. Thank you very much. I think I have to congratulate all the speakers. My co-moderator, a very big round of applause to you, Rui. And I give you the podium for saying the last words if you want, of course.
Okay, thank you so much. I suppose that your last phrase was interesting and wise enough to finish with a brilliant image. But we have still a roundtable with some honorable colleagues participating, and it will be about the same topic, but now maybe more focused about the technical issues. For that, I have the assistance of my right arm, Dr. Octavio Viveiro, that is here with me, and we have a set of questions that we're going to put and to present to a panel of presenters, of speakers, and that will be, this is Octavio, he works with me, and we thought and has grown up in my previous old hospital, public hospital. And they're going to have with us Dr. Rui Almeida, that is a surgeon from the group of Mário Nora that works in an hospital near Porto. We have also Dr. Eren Taskin from Istanbul, very well known, connected. He's the president of the IFSO. He's a assistant professor in Istanbul University, and he works, he's chief surgeon, he's a staff surgeon of the Department of Surgery, where Lissons had worked before. It's very interesting. We have also Dr. Claudio Jamel Coelho, which I want to address a big hug because his mother died 3 days ago and is still here fighting to be with us. And thank you for that effort, Claudio, and my condolences. And also Maurizio De Luca, a very well-known European surgeon with important positions in Italy and in Europe about teaching and regulating. So, Otávio, the podium is yours. Please begin the roundtable.
Thank you, Dr. Rui. For the beginning, I would like to thank Dr. Rui, congratulate him for this excellent meeting. It has been a pleasure to be here with all of us. We're going to finish talking about what's the main aspects about revisional surgery, technical issues. I would like to address and to greet all my panelists. Dr. Eren Taskin, he's the only one that I know personally. Want to greet Dr. Claudio Coelho, Dr. Maurizio De Luca, and Dr. Rui Almeida. So, as we in the last half an hour, we were talking about more or less about the same things that we talked about today, revisional surgery. And I have the first question for you, Eren Taskin. Our job today is for the last 30 minutes is to do a resume of what are the main approach to revision surgery. Dr. Dilman had already talked about it, and I would like if you would like to address this question, just how to approach the patient when you're about to do revisional surgery.
Thank you very much, Octavio and Professor Ribeiro, for this opportunity. I think the main important thing is the calorie intake and the eating behavior of the patient, because sometimes as surgeons, we cannot think about the eating pattern of the patient, because in every part of the world, in every region, patients eat differently. So when we are revising a failed procedure, I think it's very important to look up at the calorie intake of the patient and to yield the patient to get a diary of how she or he eats and how it evolved over the time of the surgery, the first surgery. Because if we don't take this into account, whatever we do, I think in the future, the patient will regain weight. So in the university clinic, we do this simple algorithm, and we search these patients with a multidisciplinary team, with the exercise physiologist and the endocrinologist and the dietitian before offering a surgery. And I myself do also endoscopy. So I think every surgeon also have to look at the pouch situation of the patient with endoscopy and the barium-graphies. So if we work up these patients very well, I think with the patient, we can decide on the best procedure, because there is no best procedure. I think it should be specified according to the needs of the patient before a procedure should be done. It can be a re-sleeve or a mini bypass or Roux-en-Y if there's a reflux. So what I want to say is there is no best procedure. There is the patient. It should be very well prepared for the second surgery, because she or he might not have a third chance. So before doing that, I think we have to evaluate it very well with the team. This is the main.
I agree, totally agree with you, Eren. The thing is, we need to discover if it's the surgery that fails the patient or it's the patient that fails the surgery. And it's about to address in a multidisciplinary team, not going firstly to the revision surgery. It's how we should approach. For Dr. Claudio Coelho, I would like to ask you, what are the fundamental technical aspects in revision surgery? I think this is a lot, but it's important to talk about it in this session.
Yeah, sure. Are you hearing me well?
Yeah.
Okay. At first, I'd like to thank Rui Ribeiro, my great friend, for the invitation of this outstanding event. It's an honor to be among such a stellar group of surgeons. And our mission here, I think, is to summarize everything that was discussed. And I would begin at first saying that here in Brazil, we have a heavy chain. We have been chained up by the Federal Council of Medicine. So we can only perform here gastric bands, gastric bypass, DS, and sleeve gastrectomy. We cannot perform any other type of operation unless under research protocols. Saying that, I think the most important issue in revisions is the selection of patients and the timing of operation if the operation is indicated. I think the multidisciplinary approach first is the key, and we try to test the compliance of the patient, and if the compliance is okay, if you find that the patient can be rescued again, and then we begin with the preoperative workup, seeking for failures, dilations, big anastomosis, dilated sleeves, as Dr. Mohit said. Dilation of the sleeve is the natural course. I think slowly all the sleeves will become dilated. It not means that the patient will regain weight. Remember that the thin patients that are not operated have big stomachs, okay? So it's not because we have the dilation that the patient should be operated on. But yes, I think the key point is first, assess the compliance of the patient, after seek for technical failures, and then discuss with the patient the best technique. I think I would summarize this meeting with the two key points. As conversion sleeve to other operations will be the most common revision operations in the years to come, because of the sleeves is now performing more than ever. And I think the poorest results in revisions, in our experience, is to trim the gastric bypass. I agree with Bruno. We have too little to offer to our patients that have failed to respond to bypass. And remember, like other specialty, we cannot save everybody. You know, if you have a pneumonia patient, it's not because you have a great treatment that the patient will succeed. It's the same with oncology and so on, so on, so on. We cannot save all the patients we have. So that's my short message.
But what if you, Dr. Claudio, but as long as we're talking now about technical aspects, you have decided to do the revision surgery. You go into surgery. What are the main fundamental technical aspects that you have to be careful when you're doing? For instance, a revision of a sleeve. Do you go with a sharp dissection? Do you use a blunt dissection? What this kind of fundamental techniques? So how would you approach, and what would be the take-home messages for our audience?
Yes, as I have said, I cannot perform any operations unless a gastric bypass in this case or a re-sleeve. I do not perform re-sleeve, never, because I think that the first sleeve failed, the second will fail too. So what we do here is the technical issues here is to horizontal stapling after the dissection, of course, and then trim the pouch. Of course, we have a upper GI assessment prior to operation. We have an endoscopy prior to operation. So we trim the pouch, and normally we use a linear stapled anastomosis in the posterior ward, taking care of the perfusion of the pouch, of course. And with that 2 meters BP limb, but first of all, we measure all the bowel because at least 4.5 tall total alimentary limb length. That's our goal to have, at least it. So we never perform a revision from sleeve to a distal bypass without measuring all the bowel, and at least 4.5 meters for tall.
Dr. Rui Almeida, I have a question about staple line reinforcements. So do you do it? You don't do it? And I would like you to mention about resuture versus buttressing or glue. Could you talk about this a little bit?
Yes, I'd like to start.
No, sorry, Dr. Claude. It's for Dr. Rui Almeida.
I don't know. Sorry.
Sorry.
Greetings to all colleagues, and thank you, Dr. Ribeiro, for your kind invitation to be in this excellent meeting. In case of the question you have made, usually we don't do reinforcement of the suture lines. However, it depends from case to case. If you have bleeding, of course, we do it punctually, or we over sew all the suture line. But normally we don't do it routinely, only case to case. We don't use glue usually, and we choose according to the tissue thickness. We adapt in terms of the height of the staple of the charge. That's mainly what we do in terms of revision.
Do you do any kind of buttress on the staple line staplers? No.
No, normally neither in primary surgery nor in revision we not usually do any oversewing or buttresses.
Okay.
Not routine.
Okay, Dr. De Luca, Mauricio De Luca, I would like to approach a subject that was talked in Dr. Dillman's presentation. It's about weight regain after Roux-en-Y. It's an off topic, and I would like you to, if you could, address the restriction versus the distalization. And how do you do it, this kind of distalization, type 1 versus type 2, the Sugarman or the BP limb distalization versus the alimentary limb distalization? Thank you.
Okay, first of all, thank you to Rui and to you, Octavia, for your questions. I congrats to you for this third international meeting in bariatric and metabolic surgery, first of all. Then, regarding the presentation of Bruno Dillemans, we show that there is a good flowchart where the first step is the multidisciplinary evaluation of the patient, the possibility of psychological and nutritional activities in order to reduce the problem. Then we have seen that there are endoscopic procedures that Bruno didn't consider too much, but have a specific reason, particularly when we have a pouch dilatation or an anastomosis dilatation, and then, of course, the distalization. There are also other procedures that he considered at the beginning, but not in his flowchart, which are the duodenal switch or the SAVIS. I have to say that all the procedures, we know that, have some benefits, but they all have some limits. And I know if you don't know, but Rui knows that there is also another approach. In the cases of a very simple approach, which is the SAGI, where we start. It's a very simple procedure where you adopt a pure malabsorption. You evaluate 300 centimeters from the ileocecal valve, and perform a section at 20 centimeters on the alimentary leaf after the gastrojejunal anastomosis. So you have a sort of one anastomosis gastric bypass. You have the first anastomosis, the old gastrojejunal anastomosis. After 20 centimeters of the alimentary leaf, you have the second anastomosis that you are performing in the sagittal. It's a very simple operation with one anastomosis where you don't move the mesenterium. Of course, it's a malabsorptive procedure, so you are in another kind of procedure. But the effect in terms of benefits and in terms of complication are the effects of a malabsorptive procedure. And this is a procedure that we are performing. Now we are waiting for 2 years results in order to have a good number of patients. The patients operated now are 138 in different centers in Italy and also in Europe. And I think that this is one of the possible aggressive but simple solution in case of failure of a gastric bypass.
And if you had to revise the Roux-en-Y gastric bypass, what would you prefer? What technique would you prefer?
In case of revision
of a Roux-en-Y.
For which reason? I should
for weight regain. Weight regain.
It depends. Depends of the situation. If I have an enlarged pouch, I adopt a trimmer of the pouch or a bend in the gastric part on the gastric pouch. If I have a complete non-compliance of the patient with a good anatomy, I adopt the surgery.
Okay.
Talking with the patient.
Okay, thank you very much. Aaron, you're one of the experts in endoscopy. So I would like to ask, and it's already been talked today, what's the role in the endoscopy in revision surgery?
I think it's getting major role because in my center we only do argon plasma coagulation because we don't have the Apollo yet. But even that, we have some cases with mini bypass. Sometimes when the anastomosis is very wide, when you do when you burn the anastomosis, you get some good results. Maybe it can be because of the scarring, especially after Roux-en-Y, because in mini bypass usually you have to, you don't have that chance very much all the time. But with the Roux-en-Y, I think when you use an Apollo overstitch, you can, when the anastomosis is dilated, you can very well control the anastomotic site. So that gives you a good opportunity in order to reduce the anastomotic sites. And then you don't have to use the surgical technique because it can add a lot of complications when you do a surgery in case of a linear stapler anastomosis, as Dr. Dina was told. So with the evaluation of like the involvement of these Apollo stitches, maybe in the future, we can even put some materials in there, like the plastic surgeons are doing. Maybe we can inject some fillings and then we can control the anastomosis. And by doing with the Apollo also, you can reduce the pouch, like in a dilated sleeve. So if these techniques are getting more feasible, and the cost is also important because the cost is very high in Turkey. I don't know in other countries, but you have to pay 5,000 euros in order to get an Apollo procedure. So if the cost is getting lower, then we can have more opportunities with the endoscopy. And many surgeons nowadays do their own endoscopy. So this is another fact. But I know that in Europe, in some countries, if you're a surgeon, you cannot do endoscopy. So this is another point of view. We have to make a position statement, I think, in order to gain our access to endoscopy in some parts of the world.
Thank you, Aaron. For Dr. Claudio, I would like to ask, how would you approach a patient with malnutrition and diarrhea, chronic diarrhea?
This is a good question. I think you're meaning after a gastric bypass or another kind of surgery. Gastric bypass.
Yeah, it could be a gastric bypass.
Yeah, because that's my reality. You know, we have had a couple of cases, and we revise after a barium meal. You can try to assess the length of the bowel. We revise the operation, measuring all the limbs, and of course the shortening of the BP limb is the operation of choice. It's not it's difficult to do, but of course we have to access prior to this some other case of diarrhea. So if we cannot solve the problem with medications like probiotics or something like that, that should sometimes the cause of diarrhea. The operation of choice is to short the VIP limb, and so we will increase the total alimentary limb. That's the goal. And sometimes one case 5 years ago, the bypass was performed by another team, and the patient had only 3 meters of small bowel. So our option was to reverse to the normal anatomy. Did you hear?
Yeah, I did. Sorry. Dr. Rui Almeida, I would like to ask a question, since you are from Santa Maria da Feira, and you guys do SADIs, if I'm not mistaken. How do you approach the patient that has excess weight loss when you do a SADIs?
Well, we till now we didn't have any case of a patient who had lose excess weight. So I have no experience in a patient like that with that problem. Neither have we had any problem with that with other techniques we do, like gastric bypass or even DS. So it's a reality that we have not faced yet with.
Your common limb on your studies is 300?
It's 3 meters, yes.
3 meters,
yes.
okay.
3 meters.
And have you ever wondered if there was a case, how could you resolve it?
If we can give a common channel and a biliary channel and alimentary channel to elongate it. So we can do a thing like that.
Okay. For Dr. Mario De Luca, I have a question. In a gastric bypass patient that had some thyroidectomy and has hypoglycemia after Roux-en-Y, how can we approach this kind of patient, and how can we treat it?
First of all, we have to identify the real case of hypocalcemia, because we can have an hypocalcemia related to the thyroidectomy. In this case, we know that we can remove erroneously parathyroids, or we can have a vascular defect of the parathyroids. And in this case, of course, we can have an hypocalcemia. But in a patient with a gastric bypass, we can have an hypocalcemia also for other reasons who contribute, like alcohol abuse, menopause, elderly, lactose allergy, chronic renal failure, hypovitaminosis D. So we have to evaluate this one. Of course, if we cannot treat it by medical treatment, which consists of 3 versus 4 grams of calcium per day and vitamin D, if we don't reach the exact value of calcium in the blood, we have 2 or 3 main possibilities of surgery. One of them is the reversal of the gastric bypass, or to to perform the anastomosis between the stomach, the gastric pouch, and the remnant gastric in order to have the transit through the duodenum, which is the more plausible solution. But in these both cases, the patients can regain weight. The third solution is to transform, to convert the gastric bypass in a sleeve gastrectomy. But of course, this is a more aggressive procedure with more complications.
Okay, thank you very much.
I had one question, more dynamic one, and it will be a question for all the panelists. And I would go back to the issue of the failed sleeve. And we found in our practice that the most common situation is to have weight regain associated with some degree of gastroesophageal reflux. So we have two problems, weight regain and reflux. I would like to make a round of you by you, and what is your solution in a case like this? Maybe first, Aaron.
Can I answer?
No, Aaron first. I asked Aaron.
Excuse me.
Okay.
I would consider Roux-en-Y gastric bypass because there's a reflux and weight regain, because I cannot take the risk to leave the patient with another reflux, with bile reflux.
And what about biliopancreatic limb of your gastric bypass in this situation?
Yeah, I would tailor it according to the weight of the patient, because if the patient regained like 15-20% of his or her weight, I would keep it in not very long.
Not very long. Mauricio.
I have a solution, very simple.
Good, that's what we need.
Which is the ORGB, because I am convinced that the mechanism of reflux of the sleeve gastrectomy in the majority of the cases is given to a hypertension of the gastric pouch. Also, in some cases, it's true to the rupture of the ligament of the hiatus. But with the mini gastric bypass, with ORGB, sorry, I think to solve both the problems. If then I have a reflux in case of ORGB, I repeat, with a different mechanism, in my opinion, I perform a Roux-en-Y under the ORGB. I have this situation several times, and in only one case, I converted then a patient from ORGB to Roux-en-Y gastric bypass, so free operation. But now, in the recent months, I am considering also the gastric bipartition in this case.
Oh. Well, that's it. I do agree with you. What we are doing is something what I call, diverted ORGB. That's the best solution for me. But nowadays, I'm going slowly to the concept of the transit bipartition, for sure. Claudio, what do you do in this patient? The microphone, Claudio, please.
As you may know, we are chained here. We can only perform gastric bypass or a re-sleeve that I cannot do because the patient has reflux. And what we do, as I told you, is trimming the pouch, converting the sleeve to bypass by trimming the pouch, in principle a 2-meter BP limb, but after measuring all the bowel, because I don't want.
Sure.
That's
sure.
it.
And Dr. Rui Almeida, your option.
My option will be like Dr. Claudio. I would convert into a Roux-en-Y gastric bypass with a long biliopancreatic limb.
That's it. So a kind of Sugarman destabilization.
Yeah.
Okay. Yes. Okay. I would note that we have here. We have finished our time. I'm very sorry. I need to close the session and the e-Congress. I want first of all to thank all of you again, mostly to the resistance, the later ones. It was a nice discussion. Thank you so much for that. And as a closing remark, I would say exactly that we have had here a set of excellent surgeons and scientists together, mostly scientists yesterday, and we have great talks with the new ideas about physiopathology, like the microbiota that we heard yesterday, or like the transit bipartition that Dr. Eudis brought us today to us. New techniques and indications like the banded sleeve by Mohit Bhandari, and all discussions about new techniques like the discussion about the YGB and the problem of the bioreflex. And of course, we had also some new tricks, new tips, like the idea of using the Apollo for the marginal ulcer in bypasses. So I suppose we had interesting things here, but mainly we had an outstanding group of people that are friends, and we had here the chance to be together, to meet each other, and to kill the saudade. Saudade is a word, Portuguese word that has no translation in English and means to feel bad if you are missing you. So I'm missing all of you, but we killed a little bit that feeling, and we are glad because of that. And we hope that in the near future, we can kill the virus and gain our friendship physically again. So thank you so much again by your presence. To all of you from the deep of my heart, hope to have you again in the future. And thank you so much. I hope that the 4th international meeting will come next year. Thank you. And let's see again our video with our idea of group.
Caring. This is the main word which guides Lusíada Saúde's work, and what drives those who believe there to be a difference between being able to treat patients and possessing the knowledge, technology, and calling to care for patients. As a result of this drive and an intensified focus on safety and quality, Lusíada Saúde has become the first private Portuguese group with hospitals accredited by the Joint Commission International, as well as the first to be distinguished with the HIM certification, which assesses the integration of technology to the benefit of patients. With a network of services across Portugal, Lusíada Saúde has 4 strategic pillars: clinical excellence, best care experience for our patients, human capital development, efficiency, and sustainability. Our core commitment is represented in our mission to help people live healthier lives and to help make the health system work better for everyone. Lusíada's caring is in our nature.
And we do care about you. Please keep safe and let's meet together soon, wherever it can be. Thank you so much. Bye-bye.
Thank you.
And
Thank you.
Thank you.
Obrigado. Vamos encerrar a sessão.
Obrigado.